Ellen Amster is our expert today. So take it away.
Awesome. Well, thank you so much. Thank you, and thanks to this dedicated crew here at the end of term. I'm sure everyone is racing for the finish or crawling for the finish, so it must be a very tiring time. So I'm very excited to be here. Thank you so much for your invitation. I even got my nails done. So when I get my nails done, I feel like Linda Richmond, you know, from Saturday Night Live, like walkie talk. So I'm ready with my nails. Ready today. So I wanted to talk about first history. So history of medicine, who cares? History of medicine, what does history do for you as a discipline? So I have a history of medicine chair, and history of medicine is in many ways one of the older health humanities disciplines, but has it been at the forefront of this new medical humanities wave? Not so much. So I wanted to kind of return to history and say, what does history do for you? So first, as a health humanities methodology, it does provide an opportunity to see how medicine works, because you look at change over time. So you look at why does medical theory change, and how do medical institutions change, and some things that were in the past were right and some things were wrong. So now, how much of what we're doing is right and how much of what we're doing is wrong, and how can we tell the difference? What are larger truths that we can derive from looking at this, the big picture, the longue durée? How do we understand institutions like hospitals and medical schools and the College of Physicians? What are their roots and their connections and their actions? So you understand how they work. So at the very base, what history gives you is an ability to have a critical lens, to do some critical thinking, and then to quote one of the founders of the medical school at McMaster and also a big EVM guru, David Sackett. He said, half of what you'll learn in medical school will be shown either to be dead wrong or out of date within 5 years of your graduation. The trouble is that nobody can tell you which half. So the most important thing to learn is how to learn on your own. The second thing that history gives you is the chronological narrative. So narrative medicine, we were talking about this at lunch, narrative medicine really borrows the notion of narrative from at least 3 different disciplines, from literature, from anthropology, and also from history. So history is narrative. History is taking 1,000 fragments that have no shape, that have no meaning by themselves, and putting them together into a chronological story. And also when you interview people, when you do what we call oral history, it's asking people to tell their story over time, from the beginning to the end. And that really is how people understand meaning, the story of your life, and how you what you think are the significant points to create meaning, but also causality. So when you take a patient history, you're asking the person, so when did this start, and then what happened, and then what happened? And so the way people describe their illness or describe their story also shows you how they understand what their situation is, how they understand what causes what. So as Jackie Duffin, who is the Hammond Chair at Queens, wrote, every physician must be the historian of his patient, and every patient the historian of his own illness. Then there's the third part, which is really what I'm more going to talk about today, which is the relationship between medicine and society. So we tell ourselves a fiction, which is that the clinical space exists outside the pressures of society, and that in the clinical space you're in this kind of perfect bubble. It's just the physician and the patient, and the physician is just dealing with that one patient, and all of these other social pressures are not relevant. But as everybody knows who's in practice, that's really not true. And all of these social pressures walk in the door with the patient, and all of the problems of society walk into the ER. So that at every moment, there are social pressures on all aspects of medicine, on physicians, on hospitals, on research, on medical practices, and on patients. So what history can do is show these social structures, this big picture that influences health and institutions and social actors, and to connect the individual to these big factors. So the physician does not understand why they're having these challenges, right? But if you can sort of see these larger structures, it makes more sense. And what history does also is connect the individual level to the macro level to show how these big factors play out at the individual level and how the individual story is connected to the big story. So in principle, history is ideal for demonstrating the determinants of health and identifying the determinants of health, ideal for helping to address what a recent stat article called moral injury, the difficulty of physicians in treating patients whose problems are much larger than a simple medical fix, and then the demoralization that comes from that. Ideal for advising policymakers, and ideal for one of the goals of our session, which is structural violence versus culture. So Paul Farmer warns against going to developing countries and saying, well, patients don't want to come to the hospital because of their culture, so it's culture blaming. He reminds us to see structural violence and structural factors as the primary issue. So poor women in developing countries may not seek medical care even when it's available for reasons that are very rational and very reasonable. So all of this sounds great, but there are some challenges to history as a health humanities methodology. And number one challenge is that history is a lot of reading. So to get this big picture perspective, this structural understanding is a ton of reading to build and understand, and also the nature of historical evidence. So the way historians write is to present all this evidence, and primary archival research is very time consuming. And so last time, I had the experience of presenting after somebody who did theater that had a 15-page interview and then a 4-page article to present. And I had 120 pages of incredibly dense material, and I thought for sure that I was going to get stoned, but I am so dead in the water and just scribbling notes as fast as I could to try and figure out how I was going to salvage the situation. So in this medical humanities movement, history is being left behind, even though they were in many ways the first, right? Medical anthropology, narrative medicine, graphic medicine. Richard Horton of the Lancet declared that the history of medicine was a moribund discipline, that it was irrelevant, right? Which of course all the historians got upset and up in arms.
What is his foundation for that?
You'd have to read it, yeah.
Was that recent?
Not that long ago, yeah.
Wow.
Yeah, and then there were some good responses. The editor of the Lancet.
Richard Horton?
So, obviously I didn't appreciate that, but I guess he's a bit of a provocateur, right? He likes to say challenging and potentially offensive things. So, but, you know, there is a point well taken, which is that history is not adapted, and history has not become a true medical humanities. And I started to think, like, what is medical humanities? It isn't just teaching doctors to be literary scholars or historians or anthropologists. That what these, something like narrative medicine is extracting methodologies from humanities and then applying it to medical problem, clinical issue, medical education issue. So it's an entirely new thing that's created through this intersection, but it's largely driven by those who have a very deep understanding of the clinical environment and what those needs are, and they're taking from humanities and applying. So it's about extracting a method and applying it to a medical problem. So that's what I'm trying to do in this health humanities portrait. have cut down the reading, but there's still a lot. So today's topic is global poverty and women's health. So what are the learning objectives, and how do the readings I chose support these learning objectives? And this is now the first part of this portrait, which is supposed to be 10 minutes, but we'll try to make it 10 minutes. Okay. So what are the learning objectives? One is to identify the structures that impact birth, women's health, and clinical outcomes, especially in a global environment: gender, poverty, legal structures, government, women's status, history. To consider gender as a category of health analysis. So Kathleen Canning is a historian, gender historian, who argues that you can't just apply class analysis to women and men equally and pay no attention to gender. She says if you look at the history of class, women and men have very different stories. Men often band together in order to exclude women from the workplace. Women's access to the market is often mediated by the family. So this very individualistic idea is problematic, and that you need to have gender as a category of analysis. And so something for us to think about is how health is refracted through gender and also through the family. It relates to women's roles in health as caregivers. Sorry, I'm a little getting ahead of myself. As caregivers and health agents and patients, women needing to work to deal with patriarchy both in the family and in society and in the state. And then the question of women's choices, which was a discussion earlier. So how free are women to make medical choices? And when women are making a choice, is that what is the role of the physician in supporting the woman in her choices, or in supporting the woman to have a broader range of choices? Where does the physician land when there are structural factors that greatly limit women's opportunities? And so they have few choices, or sometimes really no choices. This larger issue of the cultural explanations for health inequities and disparities versus structural ones. So one of the things I tried to do with the first person narratives was to choose more than one first person narrative in which everyone is Muslim. So you can't say, oh, Muslim women, because of their culture, they have this and we have that. So you have, in fact, different Muslim women who have different options and different medical choices, who are all Muslim. And so the difference between them is not who's Muslim and who's not. The difference between them is who's in what kind of situations, what kind of structural, historical, and social situation. Then using history as a health research methodology. So on Sandy's recommendation, I reduced it from actually giving you so much historical background. I think even my article could be moved to the optional section. That's something for us to discuss. To think about history as a structural approach in which you use the individual narrative to deduce the structure. So take that individual narrative and then ask questions that push students to think about why is this person's life this way? Why do they have this limited range of choices? Why did these things happen to them? And sort of use the individual to discover the structure, which is a technique we call microhistory, that you take one person's narrative and from the one narrative, elaborate the world. Go from, see how it turns into a world view. Hopefully to use my chapter, or in this case, the short lecture, to show that child abandonment is a function of industrialization and legal dilemmas and other aspects of women's status. To show that a cultural approach to Muslim women's health has a problematic colonial past. To show the relationship from colonial health to global health. To think about the physician, what the physician should do, how to support women in their choices, how to be culturally humble, how to be aware of structural issues, and then some things about global health. So global health is interesting to me because a lot of global health interventions operate between states or outside state structures entirely, which means that you don't have legal structures in which these medical interventions happen. You have people that fall between states. You have all kinds of things. And one way to explore that is reproduction in a global economy, something like global IVF. So because IVF is expensive, more opportunities for those who have money versus others who don't. Is health a right or is health a commodity? Is reproduction a right? The question of resource allocation in healthcare systems, and then the question of care for patients who cross borders and the question of continuity of care. So I actually had used the Marcia Inhorn reading, the Rania reading, and taught it to some freshman students at Rollins College, so a little practice test run. And then when I was in the airplane, I ripped out these 2 ads from the magazine on my way over as examples of sort of pedagogical tools, things that you could do. One of them, and so it's the airplane trajectory between Canada and Florida. One of them is, Daryl returned to Vancouver with a special souvenir of Palm Springs, a brand new hip. So by the time he got permission from the Canadian government to have a new hip, look at him, he went to the US and got a brand new hip. So medical tourism as a good outcome. And then here's a horror show from the dental tourism. Save now, pay dearly later. Doing your dental implant in Mexico, and then later here it is floating up into your sinuses while horrible things happen to you. So this, there is a lot of options for bringing in different types of articles or video or example for pedagogical things to open up that conversation. So does anyone have any questions about this first section? Okay. So
Anybody on, ask maybe somebody on Zoom. We can't see them, but.
Yeah, I think what we can do, because the next thing I have, this is this short sort of 10-minute lecture that would become a text and part of the portrait. So this can go away while we have a conversation, and I'll do this at the very end to give you like this last, this itself will be like a document.
Yeah, just stop sharing it. Yeah, okay.
Does anyone have any question or comment before we move to the next thing? Okay. Great.
So now you want to share the PowerPoint again?
No.
Do you want to share it again?
No, just at the end.
Okay, sorry.
Well, now is this discussion of the portrait material.
Wonderful.
So, so I thought we could start by talking about the 2 different personal narratives. One was the abandoning mothers in Morocco, and the other is cosmopolitan conceptions. So I thought maybe contrary to the ordering in the guide, that we could start by talking about the Marcia Inhorn piece, the cosmopolitan conceptions, Rania's reproductive journey. So what do you think of her quest to have a baby? What were your thoughts about reading this piece?
Well, I mean, it's fascinating. it is a world, it is a literature about which I know nothing and a world about which I know nothing. And I found myself having a variety of responses over the course of it, some of which I came back to, some of which were questioned. I was most impressed by my dislike of her.
Interesting. Okay.
Yeah, and I found myself thinking, why do I dislike this person? And the ways in which her experience, which is a natural one and a reasonable one, challenges some really basic things that I would like to see in the world. So, for instance, you know, the fact that we tend to think that the national health system, the National Health Service, is a good thing, and for her, it's this bureaucratic regime that prevents her from achieving what she wants most in the world. The fact that you know, I found myself, this is terrible, right? I found myself thinking of her as entitled.
Yeah.
And yet she is not in a position of power. She is relatively, but it helps us sort of rethink what power means and where she's positioned in terms of structures of privilege. And I think at the end of it, what I was most, I think what sort of as I'm talking it through, I think why I disliked her was that for all of her complexity, she didn't seem so aware of her, of the situation, of the way that she only seemed aware of the negative aspects of the systems that structured her situation, rather than what she had had the opportunity to do. And that's a high bar for evaluating somebody. In no better or worse than any other human being on the planet. But in terms of reading her experience, I think that's probably why I reacted negatively to her.
I wonder though if that sense of, I also sort of read her as kind of entitled, but at the same time, I think it comes from a desperation. So it's this weird combo.
Right.
Yeah, because she's so desperate. And what I came up with at the end was, how the hell, excuse my language, did these doctors allow her to have 9 cycles? I mean, that is just not good for your health. How did she have 9 cycles?
And it's I think I sent the revised version of this interview that you find that she had a significant health issue.
Yeah.
And then toward the end of the book, Inhorn has more of the interview, and you find out that like she almost died.
Yeah.
She almost died from this IVF, right? So there is this question of
but she also, at one point she's in Italy and she says, well, all he could do for me is a laparoscopy. So clearly she's pressing for services, and this physician is more than willing to do surgery for no good reason. So it's this sort of collusion that can be ultimately very damaging for her. Yeah, so what is entitlement is really just sort of her trying to be assertive to meet this very deep need.
Yeah.
So she kind of reminded me, now that I'm thinking of it, I think the first time I didn't have this perspective, but I have a lot of, I mean, I do primary care, but I have a lot of young women that I am their primary care physician, and I have this conversation with my patients a lot, and they are so, I have one patient in particular that has gone through 2 failed cycles of IVF. She is so desperate, but she asks me for things that may or may not really be indicated, but it's almost when I'm talking with her, and I kind of felt like this reading the piece, is that there's just kind of this elephant in the room. Like, no one's asking like the real question, like what is having a baby? I mean, it comes out in this piece a little bit,
She's thought that through.
but with my patient, a lot of times in this clinical encounter, you know, she's like, can I try metformin? That might help my PCOS. That might do this. And we kind of circle around and spend a lot of time talking about the possible surgical procedures. And I kind of feel like as a physician, I'm like implicit in creating this, like, I don't know, like sort of distraction from what the real issues are, which I think what you're trying to find out is like historical, political issues of power, and I don't know. So I think, I don't know.
Well, but I think that these reactions are really excellent, right? Like these reactions are really great because there are this narrative touches on these basic beliefs that we have, whether we're conscious of them or not, about justice, social justice, about the sort of ambivalent. I mean, so it's, hopefully, like history is in some ways makes you aware of the structure, but the most important thing really is individuals. How do they function in this? Like, what is it like to live this? And like, what are the aspects of this for this person, for this patient, right? Which are emblematic of a situation that other people also face. So that the ambivalence of the physician who wants to help the patient and yet is like, is this, why do you want this? And is this the good thing for you? And then the other is, what about, so there's some things that Inhorn presents as her arguments in the book, and that I talked, that's why I gave you that book review, that it, because the book review is hopefully a kind of cliff notes of some arguments about that might be useful for teaching. But I think that this is, to me, was super valuable, which is to hear like your sort of initial reaction to this person and her story. Like, it's really interesting that you're like, I feel she's entitled, or I feel conflicted. Is there anything else that you're thinking about her? Yeah.
I think my biggest negative reaction to her was when she equated her infertility as a disability. And that made me kind of examine sort of my own, like, where I'm coming from. And she kind of explains it a little bit as like, I see motherhood as more of a privilege or a choice. And I think she sees it more as like a fundamental need as being a woman. And so I guess if you like trying to think about it from her perspective, like if you characterize this as a fundamental need and she's unable to fulfill this fundamental part of her bodily function, like, okay, maybe like I can see that argument, but I mean, I think you said it well, entitlement, when you said that, it was like, oh yeah, I think like her saying that her infertility was a disability was something that I've never heard labeled that way before, and it really made me sort of think about how other cultures view motherhood versus how we view motherhood here, and how maybe that can even translate to other, other aspects of human function, human experiences too.
Well, I would say that in America too, some women would say that they have an invisible disability. Absolutely.
Yeah.
Because there's a stigma related to infertility. There is an expectation of motherhood still, even though there shouldn't be. And I don't know, like I can see some women thinking that, right, Carrie?
Yeah, and I think that that one case about the woman with HIV and the dentist office, that ADA case, they defined her as disabled under the ADA, not for her HIV status, but her HIV status affected her fertility. It was like an unrelated thing, the first test of whether I mean, it's not outside of our context either.
Right.
I mean,
So legally, under the ADA, is reproduction a basic function of living?
Right.
Or, right?
That's my question for the disability experts.
But this is also a reminder.
I agree with her, that I'm just saying the Supreme Court case of that one decision. It did.
So, but it's a good way to sort of back into thinking of disability as defined as the relationship between the person and the environment, rather than something that inherits directly.
Exactly.
And there are different environments. And while Sandy is emphasizing the ways in which that the U.S. is still in many ways that environment, it's all the stronger and more obvious elsewhere.
Yeah, for her.
Like she can't function. I mean, there are folks who can't fulfill basic social role without sort of possibility of motherhood.
Well, it's interesting too, like when we were talking about this, the very last line of the one that you had us read, Marcia asked her, do you have anyone to talk to about all this? and there are other people, but I don't see them, you know, I don't tell, and it accumulates in me, there's no way of letting it out. Up until this point, I didn't say any of it, not to the right person.
Just
But what's interesting is this entire thing is her describing conversation and interaction
That's
with
interesting.
multiple people.
That's really
She's been talking about this her entire life. I felt like when I was reading this, I was like, this is all you talk about. That was kind of my impression of her. And like, obviously she's going to a doctor to ask about a laparoscopy. Like she's talking about her infertility, but like to her, she's not. She
Yeah.
hasn't told anyone
That's
about it. So I think
Her
it's really
friends,
interesting.
Yeah, she doesn't feel, she feels
Right.
socially isolated.
Yeah.
Maybe met, you know, with her medical providers, maybe not. With her husband,
Right.
she's,
And even with her medical providers, it says she feels like she's not really talking about it. You know what I mean? Like,
aha. Oh,
like,
I see.
like
what
she's
you're saying.
talking about infertility, but she's not talking about what's really her issue. Does that make sense?
Yes.
Why she wants a child.
Right.
That's
Yeah.
why she wants a
Yeah.
child. And she
And
has,
that's what turned
she
me off
has
to her
one
too, is
child,
that she-
right?
She does have one child.
She has one child.
Yeah.
So a lot of this for me was focused on the relationship between her and her husband and how ambivalent she is about that and how she's not even sure she wants to be with him, and that she can't stand her mother-in-law. There's so much projection going on in terms of the way people judge her and think about her. But the chlamydia, he's
Right.
the story.
Yes.
And, you know, they never really talked about it and they never really unpacked that. And that probably is why she's infertile. So I thought that was really fascinating because you get the sense that a lot of the desperation is because she did choose to be in a traditional marriage as opposed to marry the guy she was kind of interested in England. And she's still torn between, you know, she doesn't really seem to have freedom of choice because of the weight of what she thinks is expected. And I wouldn't call for relationship, you know, and then the only thing you really got about the husband was the concern about the number of times she talked about the money and putting things on credit cards. You know, that was sort of what he was also talking about too. It was very interesting because you don't get the sense that they sat down and talked about this as a couple and decided how much money we can spend and how many cycles can we do and where are we going to travel. It was her.
Yeah.
Well, I know that we're focusing on this one reading, but I can't help but think about it in relation to the other.
That's perfect.
In terms of the stigma around adoption and the children who are born of unwed mothers. And it seemed like there was so much stigma that were placed on those children and their biological mothers that I could imagine that just having been through this myself was, well, why don't you just adopt? Why don't you just adopt? As if it's an easy option. And so I feel like that's kind of lurking in this story in relation to the other narratives. And then it made me understand more about maybe what makes that an option that might seem. I could imagine medical students sitting around, why doesn't she just adopt? I mean, I could just imagine it. And so then I'm thinking, well, if her context is similar to the other story, then there's beliefs around the children who would be available in that culture.
Well, she lives in the UK, right?
Right, but I don't know, this is what I mean, I don't know the culture well enough, is even if someone is from a similar culture, do those beliefs carry into other country, or the readings were put together, so I was noticing there was a lot of differences.
Well, how do you feel like that her interest in having a child and her identity are related? How do you feel the relationship there? Like, I think like something that was useful for me was just to go back through the reading to say like, okay, why, in fact, on this like list of questions that I had for students, I said, why does she want a child?
She wants a child.
She wants somebody else first.
Why does, so I think these are, you know, why does she want to have a baby? right? Why does she want to have a baby? And she says, well, she says different things, right?
Yeah.
So the one question would be, is it that she wants to give birth, or does she want to have another child, or what are the reasons that she gives?
She says that she's scared that something's going to happen to her, and
Right.
Her other daughter, she's
Right.
afraid that something will happen to her other daughter and that she'll be childless.
right.
That's
Which
right,
that,
yeah.
that sense of panic was so
Yeah. It's like the only
tangible.
time the daughter appears.
And then you also had that funny little segue where she talked about her eggs and
Yeah.
giving her eggs away, you know,
Yeah.
or helping other women. So there was some power that she felt in terms of her body and her ability. There was an assertion of individuality.
She talks about it in terms of her marriage too, and like kind of as something that she has to do in order to keep her husband around. But then she also talks about how like she would be okay without him also, and she kind of asserts her own independence. And so I thought that was kind of interesting. You know, she says that I need to have children because that's my duty as a wife. But I don't really have to be a wife if I don't want to, because I have a job and I can take care of the child, and you know, as well I can be independent, which I thought was an interesting. Like she almost contradicts herself in her own story, which I thought.
But people do that, right?
Oh, I do it all the time.
Yeah, I mean, we have this expectation that stories are going to be consistent and people are going to be, but people are not consistent.
Yeah.
So I kind of like that, you know, to me it seemed to capture this nuance.
Well, there's like in HXX prologue, she talks about her marriage, and then she talks specifically about whether her husband wants a son, like that relationship. And she says, to me, it's not about a boy or girl. But it kind of is. Like she's saying she doesn't care, but then she says, it would matter to my husband to have a son. But if my daughter had a sibling, it would calm me down. And then she starts talking about her marriage, and her marriage is on the edge of the hill. So she's kind of she's talking herself into different arguments the entire way. But a lot of it is in relation. So it makes me wonder, like this whole time I was reading this, I just wanted to ask her, like, if you had your one son, if your daughter was a boy, like how, I would just kind of kept thinking to myself, like, how would all these arguments then sort of flip on themselves? Or her justification. I don't know, it's really interesting that she has a daughter. I thought that was a very interesting thought.
Yeah, she seems so.
Hi, this is Erica. Can you hear me okay?
Yes.
Yeah. Can you hear us?
In some methods, yes. In other,
It's cutting in and out. Is there a microphone? Where's the microphone?
We can't find the key to where the microphones are. This is typical.
that's okay. I
Key of me.
good. You know, I really could just feel her African as well. You know, when she's talking about her relationships with others, and when people are trying to make assumptions about her own narrative based on the number of children that she's had, you know, where she says, you know, but people say, who are you trying to be? Are you trying to be westernized, a westernized woman? You're an African.
You cut out.
She points out that that this wouldn't have happened, you know, if she had married a Western man. So I feel like it's like she's grappling with that, her narrative for her.
So I wanted to kind of focus on and raise some specific issues that come out of the sort of comments that you've raised, and kind of push you a little bit on those. So the author of the book, who interviewed Rania, Marcia Inhorn, argues that access to IVF is a human right, and infertility is an invisible disability a dire social burden that impinges on parenthood and, quote, achievement of full adult personhood, unquote.
Yeah. Cool.
So
That's
what do
so
you think of
screwed up.
this?
I cannot believe she argues that.
What do you think of this argument?
It's so black and white. It's so unnuanced. It's so
essentialist.
essentialist. Yes. I'm so surprised.
I know. I'm kind of
Because she's not that way in person, Marcia Inhorn. I mean, I would not expect her to be arguing that.
So does that mean that, like, me as a female of childbearing age not having a child means I'm not like a full adult person? Like I haven't achieved personhood?
Well, that's the question, right? Is she arguing that achievement of it is necessary for personhood, or that having the capacity to achieve it is necessary for personhood? Because that's a subtle but important distinction.
I think that
So-
she's, I mean, I think
Because if
But
we're looking
you have
like
the
at
right to
Sen
choose.
you have
and
the right.
capacities,
Okay.
You have the
That
right to
makes me
choose.
feel less angry.
That's
Yeah.
what, yeah.
because we do, I mean, there are various, I mean, Sen, right, talks about maximizing capacities, not
Yeah.
just, so it's the freedom to choose and the range of possible options that matters, not the essential, not the actual actualization.
That's a
of
good
them.
point.
Yeah, that's
That's
But
how you would interpret.
I think that's a generous interpretation.
Yeah.
I think, yeah, I haven't read the book, but I mean,
That's a good point.
it is. Yeah, I agree.
So,
Anyway, I think it's
Allie, did you? Yeah.
yeah, this whole in the whole start of the conversation, I found myself wondering. I did not read her as entitled at all, so I've been sort of sitting here listening and trying to figure out where the entitlement is located in the text, like where we're locating it, and I'm wondering, returning to this moment where Inghorn is saying IVF is a human right, like, are we actually reading entitlement onto right from the author onto
Ronnie.
yeah, or was I just reading it in the head cold space where I am reading something different? Am I the only one that didn't sort of approach this as or get this sense of entitlement from the story?
So I chose, like, I like this piece because it brings up this tension, which is the question of resource allocation in a healthcare system, right? Because IVF is expensive, and so IVF is expensive. So and then it raises this question of the relationship between the rights of the individual and the rights of the collective. So if IVF is a human right, who's paying for it? Who's going to pay for everybody to have access to IVF, right? And so her answer is that everybody, including in the global south, should have access to IVF. And then you can imagine the answer to that is like, well, if you don't have money to pay for the people who are alive already and provide them with basic medical care and prevention against infectious disease and clean water and food, then where's the money coming from for assisted reproductive technologies in addition, right? How can you privilege that as more important than malaria prevention or care for children, under the age of 5? And so she doesn't resolve that. She just says it's a right? And so there is this question, because a lot of her conversation is about how much money she's spending, how she's maxed out her credit cards, how she's traveled all this way, how she's really spent all this money, right, to do all these things. And medical insurance doesn't cover IVF. If it's considered elective, it's not medically necessary. So making this argument that it's a disability and a human right is also a push to make it covered by insurance, right? Especially in the US. So IVF touches on the question of health equity, both between the global north and the global south, and also the rights of the individual versus the rights of the collective. So why does the NHS limit to 2 cycles? Why do they only implant so many embryos? Because, right, one is we only can pay for our IVF for so many people. You've had your 2, now it's your turn. Everybody gets a turn. We had more, we could do more, but we don't have more. So you only get 2 because that ensures that other people will get, is part of the argument. And the other is limit a number of embryos so you don't have to do selective reduction. So you don't have to do basically abortion, right, during gestation. So it is a kind of, it raises 2 important questions that you can talk about with students, which are the questions of resource allocation in the healthcare system, and how that's, and then her story, because of her therapy narrative, she's going from one system to another system to another system to another. And in some ways, because has enough money, she can leave the healthcare system where she is and go pay in another and another, and then go in this kind of no man's land in Dubai, which nevertheless is still covered by a legal regime. That she still says, like, there are still regulations. And then that raises a second issue, which is the law, which regulates not only, can you do IVF, can you use, donated eggs and sperm, how many embryos can you have, how many cycles can you have? Well, I guess you could have as many cycles as you wanted to pay, right? But what about these legal regimes, which in my review, for me, and I guess I shouldn't be interjecting my view, this should just be a discussion, but I'm like, there's no discussion of child welfare.
Right.
Yeah.
There's no discussion of, that some of these legal regulations by these different state governments are not necessarily to be mean, but also to protect children when they're born, to make sure that you don't have a baby manji type case, a child who has no mother, no father, no state, no nationality, that the legal regimes are also there once but Inhorn has this kind of repro flow, that there should be this free flow of gametes around the world and free flow of repro travelers, and you could say, what do you think of that argument, right? It is, so there are different interests that are in tension, and you can pull it out one way or the other in the conversation. And then there is this other question that's raised about disability. What is disability? What is the nature of disability? How do you define it? And she makes this assertion. What do you think about that assertion? So I think there's a lot of stuff that you can dig up for a class. Yeah.
So in terms of the resource allocation and how many embryos you would implant, seems to me, and I don't know if NHS has thought of this, but there's also evidence about low birth weight of, more than twins, right? So triplets have a lot of issues, right? Usually when they're born.
Morbidity and mortality
Yeah.
associated with multiple gestation.
And that's expensive too.
For maternal mortality and infant mortality.
Okay.
Right?
I think it was an evidence-based decision.
Yeah.
Yeah.
Yeah. So there's a connection, I think, between the evidence that exists for health outcomes and healthcare allocation that is also an interesting thing to talk about. That I don't think Marcia Inhorn, it sounds to me, I haven't read the whole book, I read her first book, but that she's just not even considering with this sort of IVF as a right kind of thing. But the other thing that seems to me with that argument that's problematic with the argument is that it's sort of ableist, right? It's about like biological reproduction. Everyone should have a right to biological reproduction, right? Rather than just whatever way, right? So there's this forcing of a privileging that's going on, I think, in that argument of biological reproduction.
Can I say something?
Yeah.
So I'm kind of struck by the overlay, or between the system and the sense of entitlement the value. I mean, I think that we're all looking at it from a Western lens too. And this idea that in certain cultures, you know, the idea or the need, like we're talking about this, the fact that she's completely isolated from, she's not socially accepted. She has, you know, her relationship with her in-laws are strained, with her husband are strained, with other women. And so it is, you know, this idea that controversy between, you know, that what should be a right for somebody, is that the right thing for all cultures everywhere, you know, for all in the world, because not everybody, and I just think that idea of the importance of children and how it overlays with someone's own identity and the value that they are, how it affects their entire social structure and their own wellness for their entire life because of the way that they're seen. And, you know, in most Latin American countries too, I mean, a woman is called a señorita until she has a child, if I'm mistaken. Also, but that's, you know, and it's like, now you're a señora, like that's when you become a woman. That's when you kind of now are part of this other group of people and you get it. And as long as you don't, you won't get it and you're never part of that. And so that is, and I'm not saying right or wrong, like if it should, you know, just that how there's even that idea that, oh, she's entitled because she can do this, where in some communities you're going to go through, almost die like she did, because otherwise your well-being and your role in society is forever going to be, you're going to be an outsider. And that level of value is different depending on where you are and what society you live in. And so it's very hard to put this blanket statement of IVF for all, or no, it should be stricter or whatever, when the way that the world around us perceives us, whether we have children or not, is very unique. So I think that piece of it, I think, was really, really interesting, because it made me realize, because I did get that sense a little bit of like, you know, who does she think she is? And then I was like, wait a second, like I'm a Westerner though, putting value on what I think, like look what she's gone through. She can go through it, but if she didn't, what would be her alternative? And that role, that where she would be in her society and in her family and everything else, like that's worth any risk that she can take, and any money and anything else that is not maybe how a Westerner would perceive the need and the value of having a child or not.
You're articulating one of the fundamental discussions we talk about in disability, Joanna, and I think that comes out anytime we talk about like female circumcision, or, you know, things that we grapple with, where we say, do you change the body to conform to the cultural expectations, or do we locate the problem in the cultural expectation, and that the real need is to change the social attitudes and value surrounding that issue. And I think that's one of the questions that I ponder here. Where is the problem? Is the problem her inherent infertility? Or is the problem the fact that she feels she has no value if she does not bear a child?
But she has a child.
Yeah, that's
You're
what-
right. You're right.
But
Yeah.
she
Well, and
has
what
a
would happen
child.
if a physician
Right.
pressed her?
But she's acting like she
Yeah,
doesn't.
Right. Yeah, I think that's what
Answers,
really
like-
troubled me.
Yeah.
Like the only time that the daughter appears is when she says, "Oh, if something happened to her, I would be without a child."
So she-
Yeah.
Right, but the value of the daughter isn't.
Right.
A child. But
The
that-
other thing I wanted to say that I didn't mention, this was in the beginning of the conversation about like what you were struck by, or what one of the things I found really interesting is, and we talked about this a little bit, but how she speaks about her husband, or how he's like kind of like, oh, how he reacts and what he's doing is central to what she's doing or what she's not, but she puts it on the side as if it's like, oh, she doesn't really get into it. So like, I found it striking the way she kind of talked about him or didn't say certain things. And it was just kind of like, oh, well, he's this way. And it's just like, you know, and it's very like in a cultural way, like, well, the man's just like that. So the woman's going to have to adapt and either like cover her breast or, you know, not, or do this or that. And so it was that like underlying, you know, however he is, and whether I got a venereal disease from him or whatever, he's never really for blame. It's the woman reacting to and having to accommodate to that. And I found that really interesting, how it was just this like she was just kind of, the way that she presented it was just kind of in that way, like, oh, he is how he is. And I just, you know, so I found that something that that stuck with me for a bit.
I just wanted, oh yeah, go ahead.
Just very briefly. So I feel bad now for sort of beginning this with disliking her right now, but because there were things that I really disliked about her, but the whole point is to sort of say, okay, why do I dislike her? And then how, what expectations did I bring to it that made me feel that way? Also, what really is going on with her, and not using that as a source of not just judging that, but figuring, well, how does this subjectivity come to be, right? And then sort of reading out from it. Just as an aside, there's also a really concrete clinical point here that medical students would love, and that's that patients like this are really vulnerable to iatrogenic illness. So someone who's jumping from care provider to care provider to care provider across systems, this is somebody who's really vulnerable to getting killed by medicine, by the doctor.
Like
and she almost gets.
Twice.
Yeah.
To the ectopic pregnancy and needed blood transfusion.
And the problem, to some extent, it's, oh, the doctors missed it. They were terrible doctors. Well, yes, but there were like 40 different doctors here. And so the more times this happens, the more likely something bad is going to happen. When
she does say that the National Health Service saved her life.
Yeah.
Right.
So like, and so in terms of medical student education, sometimes the answer is to do less rather than more, and to take a step back. And the pressure can be coming from all sorts of sides, and slowing things down is actually the right answer.
But those are the most challenging conversations to have.
Yes.
We talk about this too with residents a lot with like end of life care decision. It's much easier to resuscitate someone than to actually talk to someone about whether or not it's a good idea to offer. But I think the other point too for this and why this was, I guess, so bothersome is, and this may be just a completely obvious point, but like we can't really make those decisions about how we feel about her without examining who she is in the eye of her husband, in the eye of her community, as someone living in the UK. So much like, but it was almost funny because I don't think she had that self-realization that she kind of thought she was her own person. But so much of her identity was tied to her husband. She was like, no, it's not really. But it was so apparent to me that it was so obvious who she was a reflection of who she was in his eyes, viewing her. So I just thought that was really interesting.
And I have that too, though, personally.
Yeah, we all. Yeah.
Right?
No, but that's just
I think
a
I'm my
nature of
own
being a
person,
human.
but I'm also in relation to, there's family dynamics.
Yeah.
And I think that both articles touch up on the concept of agency, and the second one talks about it specifically, kind of arguing that when she's talking about abandoning the child, and that even the act of abandoning there is an ingredient of freedom and agency. And I really disagree with that, because I feel like how much agency do these women actually have? Because how do you separate out your internal and your external motivations? Like, how do you know what you truly, you yourself want versus what my husband wants for me, what my parents want for me, what my friends want for me, what my community wants for me, what God wants for me? There's so many different factors, and I'm like, how do you untangle that? And what does agency look like when you have so many different factors telling you what you should or shouldn't do, and how do you prioritize those different values? And I think that was one of the things that stood out the most, and I think why some of those contradictions happened when she was talking, because it was the tension between different values from different sources, which I think would be an interesting conversation point too.
So I think that is a really there's a couple of points there. So one is this question of gender and health. Gender as a category of health analysis, how decision making is refracted through family, and how identity is just treating the patient as a unit, like an N of one. Is how do these other issues, relationships to family and children, enter into values and preferences of the patient? How you as the physician should be supporting that person, and then contrasting this narrative with the other abandoning mothers narratives. Which the question is, are they patients, or there are some points at which they touch the healthcare system. Are they patients or not? But the choices that they have open to them are structured by the situation that they're in. So I think that it's a nice way to make that visible, and I really like the way that you phrase that, which is how much agency does the woman have? How much agency? And something I like about birth, as opposed to genital cutting, it's like birth is something that touches. Birth and the question of being a parent is something that everyone can think about and identify with. So anytime you start to feel, you can feel these two push-pulls for this figure, this Rani. On the one hand, you can say, well, these equity questions, but on the other hand, it's like, well, I was able to have my son, but what if I weren't? And I have so many friends, right? I mean, most of the medical students are thinking about how not to get pregnant, probably. But, you know, you're in your late 30s, you're in your 40s, you know, you're right where Rania is. You're like, I'm at the end of my clock. You're, you know, every time you go to the gynecologist, time's a ticking, what you doing, you know? So there's a way that the students can really put themselves in the shoes of this person and think like, do I want to be a parent?
I think that's a good segue to the other narratives, because motherhood is so differently fraught, right? You know, if biological reproduction, let's say from Marcia Inhorn's argument, is the end all and be all, then what happens with these narratives, right? When motherhood is sanctioned in a marriage. It's not sanctioned. Birth and motherhood is not sanctioned outside of marriage for these women, right? And so, and I think you write beautifully in the teaching guide, like how class is so important to that, right? How one of the women's, the woman who's the MD, right? Her family doesn't
keep their baby and who can't.
Right. Who could keep their baby and who can't?
Yeah.
One thing too, there's so many layers of vulnerability when you start looking at the gendered argument too, and there's sort of this biologic vulnerability of the female body and the dangers of pregnancy when you talk about like maternal fetal health and inequities, like even just across socioeconomic backgrounds. But there's also those societal vulnerabilities that this piece like really brings blank to. So I think that I just really like that objective. The gender as a construct of as a health analysis. It kind of goes on. Because you could make it very biomedical with students. But
so if you're gonna like just from a pedagogical, maybe I'll put that on the shelf, the question of teaching this in pedagogy, but what were your feelings about these narratives? Like what were the things that you learned from them, or you were thinking about them, or you could see through them? You already illuminated this really important question, which is because women are very, especially a lot of the women that are pregnant here, they're young, rural, often uneducated, often, and that the law is against them. So once, if you conceive a child out of wedlock, you're a criminal. You go to jail.
Your brothers talk about
killing you, right? Not so much in Morocco, but
the
That's
doctor
good.
alluded
That's
to
what she said,
her
yeah.
brothers
Maybe not
brothers
literally.
talking about killing her.
it's less of a, I mean, it's rare in Morocco, but it is, yeah, that your family rejects you, right? So you lose everything. You know, you become a criminal, you criminalize your activity, you lose your family support, and then you don't have a place to live, you don't have food, you don't have a bed to sleep in, you don't have any social capital at all.
So
You're subject to abuse of the worst kind. So
I missed the legal aspect in the reading.
yeah.
How does that work? I mean, a young mother becomes pregnant, or a young woman becomes pregnant out of wedlock. What are the mechanics of that?
So part of it was that in the earlier iteration of this, the feedback was that they didn't like the framing. They didn't like the background information from the author of the book, so I cut it out. Okay. But then the problem is now you don't have that information. So sex out of wedlock is considered adultery or zina, and that is a criminal offense. Only for women in the Moroccan state. Well, the only person they could prove has engaged in it is the woman because she's pregnant.
But like if a man is diagnosed with gonorrhea and he's single, he's probably not being prosecuted.
He's not being prosecuted, no.
There's no analysis, like a genetic.
Right.
They also don't force men to do DNA testing to recognize paternity. Another issue is that the child who was born, so there's a, from the French system, in order for the child to have civil status, he has to be entered into the family booklet, and it's the father who has the family booklet. So when you have a child who is born to the father, then with the birth certificate, go with the birth certificate to the adul, which is a kind of notary, and then the child is entered into the father's family booklet, and the child can go to school, can get a driver's license, can get a passport. If you're not in the family booklet, you can't get that.
So what happens?
So the children become people without legal status, without civil status. So it's another, it's a legal disaster.
Is there an institutional home? I mean, so where do they go?
The street.
Okay. Yeah.
The orphanage.
Abandonment center.
Yeah. Okay.
They end up abandoned. So another thing is, another thing that's in the framing that I cut is that there used to be the mother could abandon at the hospital and then the child could go to the orphanage, but abandoning the child was criminalized. So the woman has committed 2 crimes by coming in unmarried to give birth. She's had sex out of wedlock, and now she's abandoning, and those are 2 crimes. So now what happens is that they abandon in a public place. You take the baby outside, you pinch the baby, you pray that the police come before the dogs come. Right? So this is not a good outcome for children or for women.
So I have a problem because I just feel rage.
I don't know what to do with it.
I mean, it just makes me feel rage, and
There was rage with the guns too, right?
Yeah. No, you're right. That this is a hard one to respond to because it brings so much up.
But I think the opportunity then for the students is to say, like, this should enrage you. But there are more subtle, systematic injustices that are happening, like, in the United States. So can we identify those and figure out, like, what to do with our rage? Because it may not be the same, like, it may not be so blatantly obvious, like, I'm not being criminalized for having a child, you know, like, that just doesn't happen in the United States.
Wow.
But
it
kind of does, right? So it's not this obvious legal system where, you know.
Yeah.
But say you are a 16-year-old person.
you could say your immigration status, if you need healthcare services for your children, you want to apply for disability, you know, you want social benefits right now. That's getting pretty tough because if you come forward, that identifies you, and these are legal immigrants.
So
I think the better
comparison is the way we're going with abortion.
So yeah, that one's
I mean, that to me is a better parallel.
That's fraught but accurate.
But should kind of fill you with the same rage.
So sort of situating the person with respect to the state in terms of healthcare outcomes. That's what links these. Getting the very idea of thinking about there being a state as a medical student is pretty substantive. The fact that there are legal regimes that allow or disallow reasonable outcomes.
Right, or it makes government has the decision of what can and cannot be done.
Yeah. Within
Versus
which we
giving a
think
doctor the decision to make that choice for the with the patient.
we don't want to romanticize doctor choice here.
No, I know, but anyway, so I think that's a good way.
Yeah, I agree. I think a linkage to the state and the legal regime, and it also gets, I mean, this is exactly what Paul Farmer is talking about.
Yeah.
This is an example of structural violence, right?
Yeah.
And
that's
it's beautiful. It's actually, I hate to say like beautiful, but it's a beautiful example of it because it shows you how these large structures are influencing and shaping women's opportunities or the ways that they're maneuvering in the world, or I don't know what the word is, but functioning in the world, right?
Another question is, do these women also have a right to be mothers? Do these women have a right to be parents too? Not just women who want IVF. Do these women have a right to be mothers? Do they have a right to keep their children, right? And what about the right of the child? And so I think that would be, I think one is that it's an example of structural violence. I think the other thing I would do with this particular piece, because in fact, like one of the reasons I take students on a study abroad program and some of the work I do in Morocco is because I encountered this child abandonment issue when I was 25. I went into a hospital and there's a room of abandoned infants because the police pick them up and they take them to the hospital and they leave them there. And the doctors are like, what are we supposed to do? They're not patients. Right? They're not patients, so they round on them like once a week, and then they have failure to thrive. And they're a class of people who fall through the cracks because there's no place for them. And there is an NGO that is in one of the optional readings that was created to help prevent the child abandonment. And the way the NGO functions is to strengthen the status of the mother, to give the mother a room and a job skills. And another issue is that a lot of the women who are getting pregnant are very vulnerable. They are maids, child maids, often in homes, and they're very young, where they get raped or seduced or whatever. So, but as you see from this reading, not all the women in the situation are like that. But I would flip this and say, given this structural violence and given this incredibly difficult situation, there are some children and women who have better outcomes, and all those examples are through solidarity between women around the system, under the system. It's community-based support. This one abandoning mother went to the shrine and met this family, and then things are organized that way through women. That women are supporting each other, or this woman persuades her husband to take in. So there is this community-based support and also female solidarity that helps subvert this structural violence, which is patriarchy. I mean, it's basically institutionalized legal patriarchy. And they got it from the French. The family booklet is not an Islamic institution. It's a French. It's a French colonial.
Was this the case with the woman who became an female solidarity? Because wasn't she like tolerated in her family, but family members wouldn't talk to her or pay attention to her, acknowledge the kid? I mean, she just basically had a roof over her head. And I was wondering who's caring for the child while she's in school.
Yeah.
So I was nuts. Even when she had the opportunity to keep her child and raise the child, she was abandoned basically herself as a woman. So was there the female solidarity in that example?
I don't think that she mentioned that, no, but she has a stronger socioeconomic status that allows her to keep her child.
And that's interesting too, even in the social stratification, even when one would seem to have relative privilege, I can't even imagine how she was able to get her degree with all of that.
But it's worth distinguishing between affective ties and social movements here. So it may be that all good things in terms of social change come in part through community-based gender-related solidarity, but not all women will be nice to other women. So
Right, and unless the
Yeah.
patriarchy changes, then
yeah.
you still have the systemic, like,
How are we doing on time?
Maybe another 10 minutes is all
10
we
minutes.
can probably afford, is what I think.
Okay, good. So,
Do you want to ask the people on
Yeah.
Zoom? Yeah. I don't know if they have any.
I have a question. So just related to the Marcia Ingram comment about infertility and IVF treatment, what about a right to surrogate?
it's about IVF, her book, so
Or just
she doesn't, but I think that they're kind of pulling it back to the question of international, this is something that you could bring in if you wanted, was the question of care for the patient, the fragmented care, lack of continuity of care that Ronnie again, and that is a consequence of medical tourism. But this question of who has access to what and who can be a mother is not really a question of who's Muslim and who's Western, but who's in which kind of structure and what kinds of structures are you in.
Did she extend it to who the parents though? Did she discuss that at all?
I mean, I just because the portrait is a specific
right.
set of texts, and I mean, if you want to know more about her argument, that is in the book review that there's I wanted just to finish with
I think Erica might have this.
oh yeah, go ahead.
Erica?
Hi. Yeah, can you hear me okay?
Yeah, right now.
Great. Yeah, you know, I think that the argument that IVF is a human right is something worth exploring. I haven't read her book, but so far I just find it really lacking in any kind of philosophical basis. You know, aside from social usefulness. But to be a human right, you know, it does have to be something that's universal. It also strikes me that even the effectiveness rates aren't really even, they're not really discussed. You know, IVF, it isn't that effective, you know, anyway. So to equate access to IVF as, you know, equating access to being a mother, I think, you know, even that I think is a difficult argument to make.
That's interesting, yeah.
Yeah, so what is she arguing for? Is she arguing for access to the technology? No, I know, I read it, but I'm just saying this rhetorically, you know. The argument really about access to a technology, or is the argument about access to biological reproduction? Because it's true, IVF fails. Like, I don't know what the rates are, but.
Right, and how much is it is a construct of gender and womanhood versus parenthood and reproduction?
Yeah, and I think it would be hard even to make the argument that, you know, it somehow falls under the right to health, because IVF doesn't help a woman become healthier.
Psychologically. Psychologically.
Maybe psychologically. Yeah, maybe psychologically. That argument can be made, but
socially.
I mean, we've historically made the argument that access to abortion is, I mean, that all the exceptions that were made in the interest of the mother's mental health, which was, you know, defined quite broadly. So once we make mental health the criterion, we can do a lot with it, including throw a lot of drugs in it.
As a psychiatrist.
I wonder how much of the idea behind the right to IVF is also about mental health and saying that you have the right to try to do this, and it's not a guarantee of parenthood or parenting a child, but the guarantee that you can prove that you are trying to achieve that.
That's interesting. Yeah. Yeah. I thought you were going somewhere else with that, which is that when you are told you are valueless your whole life, your ability to access a resource becomes incredibly invested with meaning. So that was where I thought you were going with it. But but the important point there is the one you made, which is that you can at least be seen as trying to live up to an ideal.
But then that's interesting too to think
Honoring
about like the limits to transfer under the National Health Service, and then broaden it to the tourism because she's going sort of beyond. She technically NHS is needing that, giving her the option.
Yeah.
If the option fails, and so that's why she's then going beyond sort of this global tourism for medical care.
So I think that's something I would really want to the transactional nature of these services, and are they truly medical or are they transactions that are based upon a global economy?
Those mutually exclusive, though.
Yes, but I don't see a doctor-patient relationship really being established, and
I think that there's an
explored.
example of that with the first narrative where she gets really sick and she doesn't have money to go to the ER, and so the fertility doctor in UAE has her stay in the clinic overnight, giving her IV antibiotics, like treating her for sepsis in a clinic, knowing that she doesn't have money for it because he feels some sort of responsibility So I think there is some relationship, at least in that example.
I really don't. I don't know, because I mean, I don't think that should be our definition for whether it's medical. If there's like an idealized doctor-patient relationship, there's a lot of stuff that goes on that's under the rubric of delivery of medical care that would be outside of that.
Sure. Like, is there a doctor-patient relationship between the guy that decides to go to Florida and placement?
But it goes back to what Sandy said in terms of 9 times, who would do the 9th time? So the question is, you don't get a sense that she has a profound sense of the risk.
Yeah.
Right.
And that there's, it's sort of like, if you can pay for it, you can get it.
Which is how a lot of medicine is delivered.
Well, I like to explore that.
Yeah, but I think that's a
real problem.
that's a really good point for the student.
That's true. That's true.
Medicine.
Yeah, because part of and you could challenge the students too and say, as a physician, is your ethical obligation to do what your patient wants or what's in their best interest?
I had a student reach out to me this week because we've been doing shared decision making and say, so isn't shared decision making just another rubric where people can say that they can demand treatment because they want it? And it was interesting because his example was, he got the parent who brings the child in with a headache and wants that CT scan. And, I said, well, doctors really aren't supposed to offer choices that aren't medically appropriate based on evidence and indications. But we've got a lot of examples where people do push those boundaries.
Yeah.
I don't know. I think it's an interesting argument to talk about where are we right now with healthcare in terms of the transactional nature and whether people can get one if they can pay for it.
I think the tourism thing and the question of is this medical tourism, and Marcia Inhorn and Rania don't want to call it medical tourism. What do they call it? Repro something?
Repro, right? Like.
Yeah, go ahead, Allie, because I know that you know a lot about this.
Well, this is exactly what I wanted to say, that the move away from calling herself or naming it tourism is about moving away from the transactional nature, I think.
Right.
Like, call it travel or is about sort of going on a quest where you're trying to find like the right doctor, not about a kind of transactional nature of consumption.
Yeah.
And that, I think, is doing a lot of work here that is really interesting.
Well, there's even a part in the text where she talks about it, the term reproductive, like Marcia and Rania have that conversation. And she says, reproductive tourism, the first time I've seen the word, to be honest.
She's clearly thought about it enough to react.
Is when she read an ad, But in theory, what we would say is she's been a reproductive tourist. Like
but I think that Marcia Inhorn's rejection of it goes back to this, it's a human right.
Yeah.
Because if it's tourist, it's not a human right. It's only when you categorize it as something else
Right, and
Maybe
she calls
more.
it desperation. She says, I wouldn't call it tourism, I call it
Yeah.
desperation. And so she does that with her words. She says, this
And
isn't
that's where she
an
starts talking about
elective,
the invisible disability.
yeah,
Yeah.
this isn't an elective thing that I'm doing. This is because I don't have any other options. That's why I'm leaving.
Mm-hmm.
And I think that that's true for a lot of people. I mean, you think about something as basic as going to Canada to get your insulin, right? Like,
Yeah.
is that medical tourism, or is that just trying to get access to, like, you know,
Right.
desperation, right?
Or transplant, right?
Or ordering
Nancy
your
Shepherd.
So to talk about the emotional experience of living with infertility is definitely worth unpacking and thinking about. Because there is a fair amount of literature, and this conversation we're having came up in the United States when we began to freeze gametes of women having cancer treatment. There's been this big project, Northwestern with Teresa Woodruff, trying to figure out how can we preserve fertility potential for people having cancer treatments, children, and whatnot. And I think, there are lots of angles and issues that you were trying to get at in the beginning, Sammy, in terms of saying we need a more nuanced way of talking about the experience of infertility, issues of suffering. Is it a human right? Is it related to health? World Health Organization definition of health, I think, would argue that it could fall under health.
Yeah.
So, it is a complicated, interesting issue. But the problem with rights are rights always assume obligation. And somebody has the obligation to provide access if it's a human right. So that's also fraught language in a world where you've got the constrained resources and the need to do some sort of hierarchy of need and allocation.
So I know we're almost out of time. So there are just a couple of things that I wanted to highlight that have come up, and then also to wrap up. So one is this question about addressing the physician as a social actor. So physicians can't establish human rights. Physicians cannot change the economy in a place. They can't change the legal regime. So the physicians are also constrained in these different environments. But how do they empower women to make their own medical choices and support their health? And what are the ethical decisions of decision making? So that might be another way even to read these different narratives, is like, pulling out all the physicians and acting in these different moments. Like, how do you evaluate the care that this person is giving? Or, that you see that the women are constrained, but how are the physicians also constrained? There are several times where the physician says, I wish I could do this, but I can't. I want to do that, but I can't. But what are the things that the physicians can do, like having somebody sleep in the clinic overnight? Or
I'm wondering if one could even say that offering women a service for a cost, even if it's against medical advice, for self-determination. You could look at it that way.
And I think there's also power that they have in defining what is medically necessary. And especially in this situation, we're talking about the very medicalized version of health, but then there's also the psychological component of health. And when does the psychological need that women are experiencing outweigh the risks that the doctors perceive, and who gets to decide that, and what aspect of that is necessary and what?
I think too, the ideal, what would be great to plan too, is that as physicians we don't operate back. So when we have these discussions,
that's where I'm trying to go.
like, and I think that medical students come in with this idealized view that as a physician they have this moral compass, and physicians are good Samaritans, and physician will always do what is right because physicians do what is right. That's what they do, and they're not lawyers and they're not politicians, but really they're in a system. Like, there is no physician without the relationship with the patient in front of you. That makes sense. So you're not, and I don't know. So, but I think that's kind of self-evident. I think that students, that is a really challenging thing for them to grasp.
Yeah, I think that's hitting the nail, I think, right on the head, is this question of, yes, there is structural violence, and yes, women are disproportionately the object of structural violence, which is a big point that Farmer makes. And then Farmer also says, that the importance of economic rights and human rights are the most important for achieving true health. And that, I think that there's a lot of example here that shows this. And then the question is that, the physician also must negotiate these structures too. He's not, or she is not, in this kind of,
free-floating
environment,
right.
Total
It's
freedom.
not this little utopia of a clinic room.
Yeah, the clinic room is not
Right.
outside of these constraints, and then in fact, it's having to practice the best medicine that you can, given these constraints, is difficult and demoralizing, and even increasingly so. And even if the ER doctor in Cook County is not encountering this specific set of issues, there is also the same issues that you have somebody coming in who has issues that you really can't, there's nothing you can do about it. You can deal with the proximate, individual thing. And then there is this much bigger question that I think you could raise, and that I'd be really interested to hear how you see it, which is, I had a student, we did a little unit on narrative medicine and watched Rita Sharon talk about, standing with the patient and facing death. And he's like, that's not my job. He's like, my job is to patch whatever the thing is in front of me, but what the person's view of life and death and spirituality and their own identity. And he's like, that's not my job. That's outside my purview. So I think it's also this question of one student was like, this is my job, and another was like, this is not my job. So then the question of what is the physician? What is given this structural violence?
Right, but the physician also is acting in relation to the nurses and the other care team that they're functioning with. And I think this, and I don't know if I would do this with students, but there's, I think, an opportunity to point out that there can be a complicity of perpetuating kind of these patriarchal and systemic inequalities if you don't resist them, or if you don't present your patient with the appropriate choices, or prevent them from making choice,
the default
or not
is
giving
to be
them
carried along in the
to kind of perpetuate all these choices that really I don't know. Think about.
Think about, well, how would a plastic surgeon fit into, for someone who does elective surgery? So is it someone have the right to make a medically risky decision for themselves? In one case, where they want to get plastic surgery, my sister's friend died after getting the plastic surgery treatment on her face. She traveled someplace, and then she stayed overnight in the hotel and had a reaction to that. And so, that was a really, I felt just outraged by that, and how could she leave the family behind and everything. And so she made that decision. Is that different from someone taking a risk? You know what I mean?
I think it kind of fits into that. You briefly mentioned who is a patient, and I'm kind of upset we haven't talked about it yet, because I think it's a really interesting argument. But you had mentioned one of the questions, who is a patient, and I think is seeking healthcare because you need it versus want it. Is that a line that we need to draw between who is and isn't a patient? And something like pregnancy, that's a natural process. It's not an illness. How does that fit into our model as to how we define a patient? And so these women that are seeking care for, some would argue elective, some would argue but IVF treatment, are they patients? Is anybody that interacts with the doctor in a medical setting a patient? Are we how are we defining that? I think that.
And then does that change what your responsibilities are to that person?
Yep.
So the other thing, one of your questions too, is what does it mean to be doing patient-centered or woman-centered care here?
Yeah.
And that is the word that
in
will.
in both of those sets of interviews. patients,
And that is the word that medical students will have heard a lot at this
The
point.
patient-centered care.
Yeah, and so this question of, and getting back to consumerism and what must the physician offer versus withhold, and where does agency lie? That's a real conversation.
Like what's on the menu? You know, is there a menu?
Yeah.
And what about those people that need care but can't access it or like the woman that was like giving birth on the street, like she needed, my imagination was so vivid when I was reading that, like when she was talking about how she was walking and how she felt like her whole stomach was going to fall out of her body, and just like feeling like she's like this old woman, and like the moral distress that she had about how to handle this. Like I felt like I was her. Like it was so vivid. And that makes me think, okay, well, she sounds like a patient. She's not even in the healthcare system.
Well,
That's interesting.
It's interesting too to
The
think of the
suffering is
legal
something.
protections that are in order for physicians, like the Good Samaritan law. Like I, as a physician walking out on the street, I treat someone for knows what, like I think they have an opiate overdose and I give them Narcan or something like that, and something bad happens. Like I'm legally protected from harm because it was in the patient's best interest.
You reasonably thought it was.
Right, but what's interesting to think about is there is a legal structure of protection for that act.
But is that true in other countries?
Right.
Right. No.
And I know, like, for example, I think in Haiti, after the big earthquake, like, if you touched or recognized a body or something, you were responsible for it. And so people were just ignoring and leaving dead bodies all over the place because they didn't want that responsibility. And so I think that's an interesting argument too, is like, well, then how does the legality transfer locally?
And how does the legal system that's created then affect the way physicians act within? But that could tie back to these questions.
We should take a break.
Sure, yeah.
Do you have like anything you definitely want to say that you?
I have my 10-minute like history lecture. That's a piece.
Oh, sure.
That's sort of another document for you for the portrait, which later you can decide is irrelevant. I don't know. You may not want it,
So can we
but
show
just
that?
be useful, perhaps. But I think a break is a good idea, especially if the bathroom is distance from here. So.
I think it's working now.
Is it?
That's what I heard.
How'd you hear that?
Well, he used
I
it.
wouldn't pee.
Wait, I used the women's bathroom. Did it fine?
Did it flush?
I guess I didn't stay to see,
Yeah.
but
yeah.
I think
Right.
was it a patient? Did I abandon it?
In any case, if you want to take a break, I think that would be.
Okay, let's
That's a
take
good time.
a 10-minute break.
Sure.
10-minute break.
So
So come back at 4, please.
We have to get you a key.
From there.
better. Not better, right? Yeah. Okay, much better. Okay.
Much better. Much better.
It's so funny because I was at both of them.
Don't you think this is more directed?
It's a little more direct.
I feel like the
But I can't
portrait.
decide if
I feel
I'm
like
reading
the
it
portrait is
differently because-
cohesive.
Yeah.
That there's fewer things.
When you were like, it has to be history, it has to be structural violence, I'm like, okay, it has to be. So I'm kind of like,
No, this is so much better.
That's
This
why
is
I'm
so
like,
much
I'm just
better.
gonna chuck all this history and say whatever's relevant. I'm just gonna bring it in as like a structural. But actually, the thing you said that was really helpful is that it's about asking certain questions instead of having to give people like the history of the. But I
It's
thought
the
that,
analysis.
but I thought that what you would want was Inhorn's argument, which is why I gave you that.
No, I did want that.
But
I like
figured,
that.
I figured that Inhorn's argument was going to come up. This question of like, because it isn't that much in her.
It's not in the narrative,
piece.
right?
She's like little bits and pieces, but like a sort of quick, like down and dirty summary of her argument is in here. And so is, like, I was asked to review her book with these 2 other books that are all like rah-rah, rah-rah
Angel
ART.
Angel used to be part of the AIDS. Did you know that? Rachel Foster used to do
No.
AIDS stuff in the Middle East. Yeah.
Okay,
She presented in Toronto with when Gian Armino was there. And she did work with in Lebanon with she used to work for the UN or something. Or
She used to work
WHO,
for this,
maybe?
no, this thing called IBIS reproductive technology.
Equipment.
yes, but she before that even. She worked for yeah. I don't know, but she did work with Rachel Kaplan.
She was telling where that training.
Sure. You need a key, so let me give you the key.
Okay. You have one?
I have one.
Observation of the
That worked.
embryos that we did this HIV.
You don't go through
Heard
it?
about this? No.
Oh, the CRISPR babies?
Yes.
Oh my God. The world's over.
Oh my gosh.
And so there's this big,
I have a patient that's HIV positive who's trying to get IVF,
I think she needs the
but I have to send her elsewhere.
You got the bird?
No,
I don't know how, I mean, any place I've ever been, IVF wasn't covered by insurance.
It is by insurance.
Yeah.
Oh,
It
because
is.
in my day.
And another patient
this-
transferred
I
to me from Loyola
Florida
because they
State,
won't
it
do it.
wasn't an option.
There's Scott Mosen. And there's
Our UIC insurance covers.
what I got.
But I don't know how, right, so the interesting thing about IVF is a limit, right? The insurance companies can say we'll cover up to, you know what I mean? They can, like, that's why it's kind of an interesting thing versus like some of the all or nothing stuff.
Yeah.
It's far more interesting than I thought it was going to be.
Yeah.
I know, and I heard, like, she did, like, were you the work, there was another one that Sandy had organized back in May.
Was there?
Yeah, but it was the same exact thing, and all this new stuff is coming out this time.
Yeah.
But it's the same pieces.
I think
but
because it's more focused.
my
Yeah.
view of it is like
Yeah.
kind of changing.
Yeah, there was too much, maybe too much information.
Yeah, I just didn't know what to focus
I
on.
think it was. I feel like the last time I was just kind of really shocked by all these like horrible things in Morocco. Because like the whole time I just kind of sat there like. This is
So I have
horrible,
a
this is
friend
horrible.
who, a married couple who are struggling with infertility, and they recently took in a friend from Morocco who had become pregnant while she was single, so that she could deliver here and give up the baby for adoption.
Oh my god.
So all of this gives me incredible context.
That they didn't adopt the baby.
They, yeah, that was a conversation, but none of them felt like that was the right next step.
So what my question though is too is like when you start talking about gender, like when does it become a woman's right to reproduction versus a man's right to reproduction?
Yeah.
And so then at what point do you start drawing the line and saying like only women have access to IVF? But what about a man's right to have IVF and a surrogate? You know what I mean?
Yeah.
I just think that's
Yeah.
really interesting.
And what happens when we break this down from like heteronormative structures?
Right.
There've been the
Exactly,
cases
because
of
this is
people
a very binary way of viewing reproduction. I don't know, it's wild. That word.
Yeah, where is she at? Oh.
Yeah.
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 Right? Oh my gosh, did you listen to the Hidden Brain podcast? Did you listen to the one on gender? So good. Oh my
But I
gosh.
feel like there have been a lot of podcasts I listened to. that
I'm
talk
just
about
hooked on
gender.
this one recently, and gosh, who was the first one?
I'm subscribing to this now since you've told me 2 months that you're really
I know, right?
Yeah.
This is the
I
other
like
one that I
Hidden Brain.
love.
Oh, you know how I told you about my obsession with gymnastics, right?
Yeah.
USA Gymnastics just filed for bankruptcy in
Oh,
lieu of all of the
no.
Larry Nassar litigation and everything.
Okay, so it is called The Edge of Gender, and it is just so good.
Brain, what was it?
Hidden brain.
Hidden brain.
Anyway, so it's really interesting.
Oh, it's NPR.
You remind me to like highlights of this because.
So it starts with the Google memo about one of the Google executives put out this memo that said something about there's a reason that women aren't in tech or something like that.
Oh,
Whatever,
yeah,
you got
that one, yeah.
But it created like this huge sort of national conversation between neuroscientists and people, and what does it mean to, like, what is gender and what are differences in gender traits. And so they actually, and they do a pretty good job of interviewing people with different points of view. So they interviewed one neuroscientist who believes that gender is just is basically a product of how much hormones, whatever you had.
The edge of gender.
Yeah. And then the other neuroscientist they interview is like, no, like you have to think about children's brains as like, it's like there's way too much social construct of gender from like, even the language a child hears when they're in the womb, like it starts that early. Anyway, so she had, they talk about all these like scientific experiments. And then they interview the first person who was a non-binary person living in the United States.
Or who was legally recognized.
Legally recognized, right? So right, that's what I meant. They interview
Someone out in
Oregon because what happened was
Really?
so it was great though because it was one of those stories in he goes like he was like,
One thing I also thought about.
it was always a he and his driver's license. It was mostly the driver's license that said, or an organ donation card. Whatever the case was.
I think it's a driver's license because I think that's what I remember seeing.
What was remarkable about the story was how kind of simple it was to say, I don't want male on this card. I want it to be blank. And the court said, okay. And then that was that. But there was so much more to the story, obviously. And leading up to that,
What are we gonna do with
just the whole story is really good.
That encompasses both sort of the debates over gender as biological versus socially determined, but also like the sort of social position of people who are non-binary.
I didn't realize that, like, I had this really interesting conversation with a couple of friends of mine over the weekend about Northwestern. I guess there's like a group there that still does like gender gender assignment surgeries for babies that are born that are intersex that could either go either way, and the parents just kind of make that decision for them, and they like. They were talking about like they measure like if the clitoris is a certain like,
and then that just makes the decision.
Like the length, right? If your clitoris, if it's like greater than an
If you
inch.
have an algorithm, it will solve everything.
Right. Seriously, like if it's more than 3/8 of an inch or between 3/8 of an inch and an inch, it's intersex. If it's more than an inch, it's less than 3/8, it's a clitoris. And
oh my gosh.
like just the clinical, and then they just
That's
decide,
amazing.
and then the parents like, do you want a boy or a girl? And
But often they're also like, do you want to bring up like PowerPoint? Yeah. I'll make you full.
That is so fascinating.
Like,
Yeah,
that's
so this hidden brain is good because it just, I mean, the thing about the hidden brain is it just kind of like tells all these stories and then just
It's very
leaves it there,
NPR, yeah.
Yeah.
am I gonna
It
cry?
just kind of puts it out there.
No, it's not like This American Life.
No,
It's more science
Okay.
journalism. It's more science
It's more
journalism.
reporting. I feel like it's more reporting than.
Yeah.
It's science
I've been
journalism.
listening to Believe, which
Yeah.
is also NPR. It's Believed. It's about sexual. They've been focusing on like Larry Nassar victims and sexual assault. Most of them are like ones from Michigan State, not necessarily gymnasts, but like sort of painting the whole picture, like so with microhistory, where you use like the individual to sort of
and then
craft
I'm
the
making-
story
I'm making
around the
notes.
larger issues. It makes me cry every time I watch it.
Or even asking a question that Ellen
No, this is
and then
this
just
is
propose.
I can't find the
But I
difference
really
between
like
the
to
two.
push places that think about that.
Huh?
That your job
Because
is
they
a
just,
doctor
they don't know,
Yeah.
they don't know.
to
And
be president, to be a midwife or diabetic.
I can't find the
And
difference.
then
You're talking about Emory.
Well, it's not an M1 stretch.
It's called,
We're going to do
the Jefferson
step
one
design,
is
and Michael's been
called
working on
Abounding Contradiction.
this
Okay.
framework
When was
for
it? What
Block
day?
8,
For what?
November
Block
26th.
8, which
Oh, it's
I
right
I
there.
do think it's
Yeah, it's
exciting
one of the
because
first
it's right
ones.
before they
And,
go into their clerkships.
This one,
And
were
most
made
of them
in
during
the,
phase 2 will have their first step experience in some form or another.
And she's the primary.
Oh.
Okay.
So we want
Any
to
other ones I should
introduce
download
them
on here that are
to the
amazing?
interprofessional hospice team and talk about the different roles, but he's got a video. And I
There's
was
a
also
the
thinking-
video, it deals with caretakers, and it was part of a project I was involved in at Neomed, and it was using the 5 families talking about their experiences, long-term caregiving for a dying
Or you, I
patient.
mean, you can, I like the questions,
and-
Ellen, that you have.
Getting residents and third-year medical students to see caregivers as a resource in some ways, building partnerships with them because they know so much.
Oh, yeah. That's
Right.
interesting. Yeah.
Yeah, and then
And actually, the doctor is the least important member of the team.
Oh, God, yeah.
Yeah.
in the hospital. Oh, yeah, yeah.
Yeah, often.
Okay, I think we should get started, so that we have enough time to do the Anna Maria.
Sorry.
I can sing your name.
I'm just gonna.
Do the last one, too.
So, we're gonna get started on the second half. Joanna, are you here? Yes. So I just wanted Joanna to quickly give you an update on the testing. Shay's then going to talk about the schedule for 2019. Then Ellen, you can give your spiel, and then we'll open up. Okay, so there's kind of some. Okay, Joanna. We can't hear you.
No volume.
Are you recording it? Okay.
Okay, so a couple weeks ago, I lose track of time, Michael provided the session. Sandy and I were there. Sandy gave an overview. And I guess we could say it was pretty dreamy. I mean, I think that we were overwhelmed by how much they really loved it. And they really, really appreciated it.
Wait. Joanna,
Yeah.
can you give the
Give us a
background?
little
Like,
context.
who are the
Oh,
people?
I'm sorry.
How many
So this
students?
group
Portrait. Which portrait?
What, yeah, what,
Oh,
the
okay.
who, what, where, when?
Yeah, back up.
Okay, so Rebecca Garden, it was her portrait about refugees. So it was, what?
No, she revised it.
It was her revised portrait.
Yeah, it was a revised, I can't really say exactly what the readings were, but there were 3, wasn't it 3 total? 3 things they had to read?
Yes.
So I can't speak to the specifics of what, but it was, it was very, the reason that they were, more than anything, they just kept saying that the piece was so moving. It was so poetic. I mean, it's an author who, it's a very poetic writer who's also a refugee. And they just, they said that they came into it being like, oh, no, look at this reading. And then once they started to do it, they just couldn't take themselves away from it. A couple of students mentioned during the session and even emailed me afterwards saying that it made them, as first generation U.S., in U.S. education and just in general, just first generation from refugees, both from the Philippines and from, I don't remember where, a country in Africa, that it made them think about their positionality and things that their parents had gone through that they had never thought of before, and that they were really moved by it and really touched. So it was really quite incredible. They had some really profound thoughts. I mean, this is the urban medicine first-year medical students. So they're first years, and the first years tend to be like things a lot better than second years do. They're a really fantastic, pretty tight-knit group already. So there's 18 of them. And so they're just fantastic. I mean, we select them out of a pool of applicants that already are really interested in underserved and underprivileged healthcare, for underprivileged individuals. So, that, I think has something to do with it. So the participation was great. At the at the end, you know, we told them at the beginning, we're piloting it, and we gave them the agency to really be honest and give us feedback and say, you know, you are a part of the decision-making process in terms of, should we change anything? Is this appropriate for everybody, for only certain groups that are interested, and so forth? And they felt that it was important enough for everybody to receive, but felt that it really needed to be in some sort of small group setting, and they gave us some really good suggestions. They did say that they preferred this method over what HIS is currently providing in the general curriculum, which my understanding is a lot bigger group and kind of maybe doesn't, maybe covers concepts in a more general sense than really getting into, you know, obviously using a personal narrative is a deeper dive to explore some of these issues. So they did mention how much more they felt that they got out of a session that was more intimate and really focused in on the literature. So I think both for students that have had a background in maybe social science or differently, they really, really appreciated having this show up in the medical curriculum, and those that had not been exposed to that type of learning, maybe they were, you know, science majors or so forth, there was no question that they could see the value, and they appreciated the reprieve from studying, you know, biomedical content. So I don't know, Sandy and Michael, what I'm missing.
I would just add, tomorrow Joanna is going to teach the M2 urban medicine group, Gretchen's portrait on rural medicine. And Michael was totally a brilliant teacher, and really, I thought, drew out some just wonderful discussion with the students. So one of the things that they did say in the comments was that they felt that these portraits would have to be delivered by people who are knowledgeable, that otherwise it would flop. But we kind of have discussed that amongst ourselves, and that, to me, that's become more clear. So it also creates somewhat of a dilemma for the dissemination of this nationally, but there you have it.
So was it a 90-minute session?
No, we did about 75 minutes for the actual teaching, and then we had them for 2 hours, and they stayed till the end talking about the portrait.
I'm still thinking about medical colloquia, which is 90 minutes. How much?
Oh, we could have easily filled 90 minutes. Yeah.
Yeah, we used a significant amount of time getting their feedback and so forth. So that was, you know, the other, I keep remembering and then forgetting one other thing. Oh, the other thing that I think is really important that Michael also did is printed out pieces of the narrative or of the stories and had them read it aloud. You know, they each going around and having them read it. And so I intend to do that as well. Even though it wasn't as much reading for this one coming up. Again, just to bring them back into the story, and also, you know, assuming that there are some people in the audience that did not do the reading, you know, and not to leave them kind of high and dry. So just making the assumption that not everybody might have gotten to it or gotten as deep into it. So I think that was really helpful too, and it really brought in their participation. And for the one tomorrow, this is, I don't know if you guys remember that Gretchen, we had said, you know, your perspective as a person in performance studies, your orientation, the way that you see this is possibly, it might be really valuable for the students to hear that. So she actually made up a video for the class to start the class that, you know, shows her and talks a little bit about the background. And then she has like a 2-minute video of the two folks in the interview, the doctor and the patient, driving through the mountains to get to the center. So it gives them a visual of rural healthcare in some of these really precarious situations. So I think that was a nice addition to her piece. And then we intend to also have them do that drawing piece where we draw the ER and talk about their perspective and so forth. So I think I'm looking forward to it, and yeah, we're crossing our fingers. So we'll have that feedback next time.
How big are the groups?
18 to 20.
Yeah.
I will say that it went so well that I was crying.
Oh, good.
And I leaned over and really, I was like, I said something to Joanna.
I think I'm in tears. Like I'm in tears.
I was crying. That's how good it was. So anyway, I think we're on to something. That's the point. And you know, every portrait's going to be different. Every way a teacher delivers that. But there's something about this that is getting, at least in this particular case, was received very, very well. Shay. Yeah.
They did reiterate several times how important it is to have a reading that really captures them. And so I would say that maybe this was conscious on Sandy's part, or or it just happened that I think it's going to be an interesting contrast. And I think it was a good selection to have portraits that are pretty different, because I think this rural healthcare one, it's shorter and it's not. I think you could say that the interview is not as engaging maybe as the other one, because it's a transcript. It's not this, incredible writer with description. And so I think it'll be interesting. It may be very appropriate, less reading for M2 students that I don't know. So I think just having these two very different portraits, it'll be interesting to see what their thoughts are about reading something that maybe wasn't as intriguing or engaging, or perhaps it is, but that's kind of my thoughts.
Okay, can we move on to Shay, just because I don't want too much time being taken away from Ellen.
Yeah, I'm done.
Thanks, Joanna.
Just want to take a quick look at the scheduling stuff that I've been emailing everyone about. Sorry, there are so many emails that have been complicated. So I think we have 2 of our 4 dates relatively solidified. They are the 2 later dates, the June 13th and September 26th dates. And then we have the tentative April 11th date, but I know that Joanna is teaching on Thursdays this semester, so I might send out something to everyone just to see what day we can do, like that week or the next week. So it's the same general time period, and trying to get as many people in the room as possible. And then the first one, or what might be the first one, has been the most up in the air. And originally we were aiming for February, but it doesn't look like it'll work that well. So we're thinking about second week of March, so that we're not getting too close to the next one. And at this point, really, our only other option would be to go to like November, which would make it really hard to do the wrap up for the project and producing all of the materials that are supposed to come out of it. And again, we have some flexibility in the exact day there, but does that sound reasonable to people at this point? And I can send out probably 2 doodle holes for just the days for that second week of March, or roughly second week of March.
That'll be the first one. Like the February one's not.
Yeah.
So can I just, I would be, and I'm kind of the stick in the mud, or the one that's been causing the most riff with that March date, only because February I'm completely consumed. I'm just concerned that we start in January and we're all settling back in and starting our classes and all this stuff. And I feel that I'm not going to be able to dedicate the amount of time to something that is not, so new and so unfamiliar, and working with new people and coming up with the materials and having it all ready to go. I feel like that's really early. Me personally, I just don't feel like I'm going to be as ready for something that early in the year. So I don't know if there's any way. I mean, is there a reason why we're keeping a gap, like such a gap between them? Is it because we don't want to bring people together too often, or?
Yeah.
Yes.
Yeah.
Yeah, we have one in May, couldn't we?
We could do May or October, if that's better, but then from January to April, we will have nothing. You guys will not see each other. I know you'll miss each other, but.
I mean, what about, is there any interest in doing something that gets us together to share challenges where we're at, like just because I think across group.
That's a good idea.
Working like check-in.
That's a great idea.
Oh, that's a great idea.
Like
In February?
I like that idea.
Yeah.
like late February maybe.
And that'll kind of keep us accountable to.
Exactly. Yeah.
Okay, that's good. So
And we
Shay,
can physically get together with our people.
Right.
okay, I like that idea. Thank you. So Shay, can you follow up on that?
Yes.
Okay,
I will send everyone more emails. Please respond. I
okay.
appreciate it a lot.
Yeah.
So back
Sorry about
to
that.
Ellen's, what, sorry.
Second, I just want to make sure that I am writing down all of these things that I need to follow up on before I try to think about what you're saying next. And then, so if we are doing the meetup of some sort in late February, what are folks thinking for that last workshop?
How about May?
Are we going for May? May and October are the options.
May's fine.
What about August?
Can you tell us when? Or February?
August.
Yeah, I'm gonna send out something to figure out like what.
My clinic.
We don't.
I just have to put in
Oh,
my
yeah.
3 months notice.
What time away?
Money.
I love the like quotes and the eye roll that went with that. That was
Okay, is that okay?
Yes.
Okay,
Awesome.
so
So
Ellen.
Ellen, thank you for being so patient.
Oh, sorry about that.
Tuning out.
We're just not gonna see each other, and so,
Okay.
we wanted to get some of this out there. Okay,
Yeah. Okay. So this may not be the final version of this, but this is maybe a 10-minute quick overview of the development of maternal and infant health in Morocco from the pre-colonial to the colonial to the post-colonial, to give a kind of an idea of some issues. And it could also just simply take the place of the article if you want to bump it all together. So this short video should demonstrate the complexity of birth, the interest of governments in population health, how government programs and policies are tied to social theories of the family. Governments historically are interested in population health and maternal and infant health, not because they support women, but because the state has an interest in labor or soldiers or voters. And secondly, the question of colonialism and health, because colonial systems transitioned to global health for most of the developing world. So a lot of colonial structures remain in global health. And the question of, it's fine. I'm just giving a quick overview and then I'll start talking about the content later. Then the demonstration that medical clinics, despite colonialism being an undemocratic system and an exploitative system by the French, still had important foundational support for women, and that the structures created during the colonial period endured to the post-colonial period and now nourish maternal and infant health in the post-colonial period. So very quickly, and this is just a quick overview, that birth before the colonial period was mostly the province of midwives, and that midwives had many different roles in Morocco before colonialism. There was a kind of state functionary called an arifa, who would take care of the sultan's family. Women who had medical roles in institutions like prisons and insane asylums were also called arifa. And adila is the name of a woman who testifies before a court about issues about pregnancy, menstruation, filiation. So she's a kind of medical legal expert. And then the person who delivers women is the qabla. And the person who would be qabla, often our neighbors could be a qabla for each other, or there would be one woman in the neighborhood that would be older and have a lot of experience and authority, and this person would be qabla. And in practice, the qabla would mediate between different medical systems, a Galenic, basically a Galenic medical system, visitation of saints, and Islamic law. And then when the biomedical system came, they add biomedical remedies too. So Morocco became a protectorate of France in 1912, which was added to the French Empire. And the French governed Morocco from 1912 to 1956. The first medical service introduced was for French soldiers and then French civilians. But there was also medical care for natives from the pre-colonial period, because Governor General Lyoté, who was there on his horse, thought it was a very important strategy to win over Moroccans to French governance. He called it peaceful penetration. He said, give me a doctor and I'll send you a battalion. That you don't need to conquer people if you win them over with your doctors. But hospitals were created at the regional level. France expected Morocco to be a colony on the cheap and wouldn't spend money. So the regions had to provide their own money. And there was not attention to maternal and infant health care. The only people who cared about maternal and infant health care for Muslim women were the very few French women doctors. The French women doctors were the only ones who cared. Françoise Léger created the first maternity for Muslim women. She became good friends with the notables in the city of Marrakesh, and they gave her this beautiful traditional house that she then converted into a very small maternity hospital with 12 beds. So it was a very small number of beds. And another thing that they did for her was to, the notables asked her to examine and license all the traditional midwives, the Pavlet, and the ones that she thought were good at practice got this ID card, and the ones that weren't were barred from practice by law. So the notables of the city of Marrakesh embraced her as a medical authority and asked her to do this. She was a French. She was French physician.
What kind of physician?
Sorry?
What was her? So OB-GYN didn't exactly exist.
It existed. She was an OB-GYN, but she was also a generalist. You have to be everything. All these physicians were everything. They had to be everything. There were 9 women physicians in Morocco, I think, in 1925 or whenever she made that maternity. So the French protectorate government only got interested in creating maternal and infant health programs on any kind of scale for Moroccan women in 1948. And the reason for this is represented here on this map. So Morocco industrialized and urbanized in 30 years and became this industrial miracle, this huge source of phosphates and food and agriculture and building. And they used Moroccans as troops in the First and Second World Wars. They used them to replace French labor in the mines. And as a consequence, tuberculosis became a national epidemic, and you have tuberculosis exposure throughout the entire country and in these very rural areas. And this is the BCG vaccination campaign that took place after World War I. So the reason in 1948 they were worried was to prevent nationalism. They were worried about the Moroccan nationalist movement. They didn't want to lose their precious colony, and they were worried that their workforce was tubercular, getting sick, so they needed to protect their workers. So what they did was introduce these, what they called maternal and infant protection, protection maternelle et infantile, which was part of a larger effort to modernize the Moroccan worker. And this is an example of new housing that was constructed to take Moroccans out of shanty towns. So there were huge shanty towns that grew outside of every industrial center in the north because there was no city planning for them, and then they just made their own housing out of leftover construction materials. That's the name of it. So the French word for shantytown is bidonville, So bidon means like a big drum, right? So that you would just take leftover construction materials and make a city of them. So there were a number of cultural assumptions about Moroccans that entered medicine. One of them was based on polygamy. So there was an argument that all Arabs were syphilitic. And in fact, you found this in WHO reports into the 1960s and 70s. So this Georges Lacapère and this idea was repeated universally by the French physicians that Moroccans were 80 to 100% syphilitic. And all metabolic disorders, skin disorders, developmental disorders, birth defects were all diagnosed as. So syphilis was overdiagnosed in Europe, but it was really crazy overdiagnosed in, in Morocco. And they argued that it had a special etiology based on the Arab brain and Arab behavior and Arab culture. Another cultural argument was now that they were interested in maternal health, they criticized in every way the Muslim mother, that she was a terrible mother, an inadequate mother, and that swaddling suffocated the child, deformed the child. I thought that was very ironic, given that I spent like $120 for one of these slings for my own son, and that it's all about how you should be swaddling the baby and against the body and all these things. So all the things that Moroccans did apparently are now all the rage in all the mommy blogs. But the French were criticizing. This is one example of the many ways in which women were criticized. When there were finally maternities for Muslim women, the patients who arrived often arrived after several days of labor, infected, and many had a collapsed pelvis. And so the French physicians practiced symphysiotomy, which is something that had been rejected in Europe itself, but they did it as a last-ditch effort to save the mother and the child. If they did a C-section, the woman would get sepsis because she's already infected. Symphysiotomy is the bisection of these ligaments at the bottom of the pubic girdle, pelvic girdle, I'm sorry. And it was adapted by a physician in Brazil, Enrique Zarate, to respect the upper ligaments. But the problem with symphysiotomy, obviously, is if you cut those ligaments, then the woman never heals properly and she can't walk. So it had been abandoned in France, but they did it in Morocco to save women who were in extreme case. So the physicians are like, why are they coming in this terrible condition? It must be because the traditional midwives are so awful, and also because the women are so ignorant that they don't know that they need to come to the French doctor. So traditional birth attendant would birth in this way. This is the woman would deliver sitting up. Her back is braced by one woman, and then the qabla sits in front of her to receive the child. They said, oh, the qabla is so ignorant, she has no understanding of birth itself. And biomedical birth is not very pleasant for a hospital, as you can see. So there would be other reasons that you wouldn't want to go to the French. But the primary issue actually was about nutrition. So there was one physician who said, why is it that these Moroccan women have a normal first birth and a normal second birth, and then the pelvis collapses and the woman has to have a C-section? And he thought to x-ray these women, and he found that their skeletons were so decalcified by the subsequent pregnancies that they exhibited the loser syndrome and pseudofracture. So the reason for this was malnutrition. So the problem with Moroccan birth was not a question of culture, but of food, not having enough food. The people that were crowding into these shanty towns in urban Morocco, the whole family would live on 7 francs a day, and the women were not getting enough food. So when they gave them vitamin A and vitamin D and milk, then miraculously they were healed and able to walk out of the hospital. So it's really the colonial economic situation that created the crisis, and not culture or some other Muslim issue. So that the source of Moroccan women's birth problems was rapid industrialization, poor nutrition, and living conditions in shanty towns, all of which were caused by a lack of urban and social planning by the colonial authorities. There are still shanty towns next to Moroccan cities, but this is something that the Moroccan government is attacking as best they can. So child abandonment, which is another part of our story, has occurred in many parts of the world. In fact, it is always concomitant with rapid industrialization. So people coming from the countryside into the cities, young, vulnerable girls who go to work in factories or in homes, who are either raped or seduced and end up pregnant. And so you had, these are just a few examples of histories of child abandonment in Russia. You had also in Europe, the United States. Here you have street children in New York City. So this is a common phenomenon. It always comes, so history can show you it always comes with industrialization and these living conditions. It's related to women's poverty and lack of social status, to rapid industrialization and urbanization, and to legal frameworks that are prejudicial to motherhood outside of wedlock. Nevertheless, there was an important transition from colonial health to global health after Moroccan independence in 1956. Many French doctors and nurses were invited by the independent Moroccan government to stay on. Otherwise, the director of the Moroccan Protectorate Health Service left Morocco in order to join a new organization created by his father-in-law called UNICEF. And he represented UNICEF at the WHO. So the transition from colonial health to global health, the same personnel that had been in colonial government then become the positions of world health and global health. At the same time, there's a continuity from women physicians and social workers in the colonial period to the post-colonial period. This lady who is mentioned in my chapter that I gave you, Aisha Ashanna, founded an NGO called Solidarité Féminine that supports unwed mothers so they don't abandon, giving them a small stipend and housing allowance and childcare. And she became a social worker because Noël Courtecuisse, who had been the director of Protection Maternelle et Infantile in Rabat and Casablanca, was invited to stay on after independence for 10 to 15 years. And she saw Aisha Shanna as a teenager typing in the tuberculosis service and said, you should go to nursing school. And Aisha Shanna said, I can't do that because my whole family depends on my salary and I've never been to high school. And so Noël Courtecuisse organized for her to have a fellowship and to get into nursing school, and she got brevet and became a social worker and then went on to found this NGO. And Noël Courtecuisse was still going back to Morocco to work with her Moroccan collaborators in the 90s. So that there are these transnational networks of female solidarity that have endured past colonial, and with the rise and fall of these political regimes, it's the medical practitioners that in many ways form the bridge. So that's it for this little history lesson.
Thank you.
Thank you.
I think adding to that, like when you were telling us about the legality around abandonment and getting pregnant out of wedlock, I think that might be good context to add to that presentation.
Okay,
in the future.
I could add one more slide about
like just current policies around birth and child, or
something akin to the shantytown slide, but about
like a quick
criminalization.
current legal regime.
Is that something that would be like for dissemination of the portrait? Would you record yourself narrating those slides, or would that be something where you
it would be just that, more or less, right?
Yeah, it would be that with one more slide about the history of
With some lecture
That,
notes.
I think
The
it would be
narrated
powerful.
narrated
to have.
Narrated.
Like I would not be able to deliver those slides to us.
Or with
I see.
lecture
No,
notes.
yeah, it would be recorded.
Way. I mean, I could read
You could
off
either
of them.
record it or you could put PowerPoint notes, you know,
Yeah.
for
That
the
would be-
person
yeah.
to deliver it.
Yeah.
Either, whatever you prefer. Yeah,
We can
so
talk about it.
the stuff with the legal stuff, some of it is a family code called the Mudawana, and some of it is criminal code. That actually, Morocco has 3 legal codes, which are an artifact of the colonial period. Again. So they have an Islamic code, a civil code, and then they have like a special family law, and that things like sex out of wedlock can fall under criminal law, but issues about children in the family booklet is under the family law code, which has been revised. People are very conscious of this being a problem. So there's actually, it may have gone through an effort to allow single women to have their own booklet. So that if there's a woman who is the head of household, she can have her own booklet. Because otherwise, what would happen is that she would get added to her father's booklet. Like if her father would accept to add the child to his booklet, then the child would have legal status.
So that's part of what I still would like to know more about, because having a woman, a single mother going to medical school, is so interesting to me. How common is it for women to go to medical school, and can women divorce there, and do they get to keep their money? And I think the professional roles of women and what rights they have would be very interesting.
Well, actually, women have the guarantee to their own property in the Quran. So Islamic law is very supportive of women owning their own property in a way that was not true of the Christian world until like 19th or 20th century. Like, women didn't own their own independent property in much of the West until the 20th century.
Then they were supposed to go to her husband's family to take care of her.
Not
like she
not
was
necessarily.
I thought it was the husband's family, where she was supposed to marry like a brother-in-law.
She doesn't have to marry anybody, and she has her own property. So if you're a widow, you can live alone if you have enough money.
What if you're a widow?
Then you're in a bit of a bind.
Who owns the child?
An issue. Sorry.
Right.
Who owns the child?
Right.
So
In the U.S., it took a long time for women to have a claim to the child after a divorce, right?
There, divorce law. That's a good question. So there's, usually the father has more right to the child than the mother in divorce, but the father owes the mother allowance in order to raise the child, nurse the child.
It's an economic obligation. But legal
And in
right.
marriage, the husband owes his wife both living allowance and support and sexual fulfillment.
Is this more broadly applicable to other countries in the region that were former French colonies, as far as kind of those like French colonial laws that you said sort of persist?
Well, it just depends on how much the different colonies adopted or rejected or made something completely different.
Yeah. So
the question of adoption is there's part of the Quran that there's a story in which Muhammad had a freed slave that he tried to adopt as his son, and then there's a Quranic verse that says identify the paternity of the child. So and this is used as a justification to reject plain adoption. We call it plain adoption. So like in for example, U.S. context, we have this plain adoption in which the child becomes, as far as the law is concerned, the same as your biological child. There's no difference. that legally it's the same as your biological child. But in this Moroccan context, a child that's not your biological child, you can enter into a kind of permanent foster care called kafala, but not have that can't. You can't have them be recognized as the same as your biological children. People then subvert this all the time. They pretend like this was their child, or people look the other way, or there's as much as possible. But there's some shuffling of children in extended family. Yeah, that happens. Yeah, in many contexts that the child will kind of
like if like a family member can't have children, like the sister gives one of her children to the other sister. And but it's
you're not, I mean, like legally you're not supposed to do that, but
right.
what you do is but in a place like Tunisia, they just said, we don't care what it says in the Quran, we're going to have plain adoption. So,
and the origins of that are Islam as opposed to French.
So the adoption issue has to do with a certain interpretation of the Quran, which is very patriarchal, but the Tunisians are also Muslim, and then they were just like, nope, we're going to have this open adoption. That's what it is.
Here's an answer. I had a friend from Lebanon, and she was describing a lot of what you were doing with the book. Like she was talking about in reference to voting, like her thing, or that people know your last name and they know where you're from because it follows the male. And like to vote, she would have to go to this village that she'd never lived in, wasn't born in, out in the rural areas, because that's where like her great grandfather whatever started the book. And it only shifts like when you're married and then you go with your husband's book. But it sounded very similar to what you're talking about with like legitimacy of the children and that kind of thing, which you said was a French thing. Right.
So the book is French.
Yeah.
This thing with the book.
But Lebanon
was under French.
Yeah, which is why I was like.
Well, Lebanon is under the French, but then Lebanon has a particularity that's only Lebanon and not every place else, which is the French carved Lebanon. So Lebanon and Syria and Jordan and Iraq were states that were all created after World War I by the French and the British. So the French got Greater Syria, which they made into Lebanon and Syria. And they wanted Lebanon to be a state where Christians would always be the president.
Right.
And Lebanon always had all these many different ethnic groups, Christian, Sunni, and Shia, and Druze, and whatever. So they have this very complicated system of representation where each group has a certain representation. And then it's this very careful balance of all these groups in which the Christians will always be the president. The president is always Christian.
Always Maronite Christian.
Always Maronite
Christian. That's in the Constitution.
To the Constitution, and then the number 2 is the Sunni, and number 3 is the Shia, and so they have this is a state system and a constitutional system that was created by the French and then perpetuated after independence, but that's particular for Lebanon. And then obviously it fell apart with the Lebanese Civil War, where they were just like, no, we don't want this now. Now we're going to fight.
I'm learning an enormous amount here, but we are very far afield from
let's get back to.
So no, this is really. I mean, I would love to sit, but we are very far afield from what our focus of teaching a medical student.
Yes, let's do that. Thank you.
So I wonder if you could say 1 or 2 words about, given how much sort of revising and rethinking and the role of, and this is something I struggle with a background in history, is what role do you see as history playing here? I think it's important, but in terms of the focus for the unit, what role do you see history play?
So what's really hard is that Sandy set me an almost impossible task, which is like it's much easier to do history where it's like, let's talk about some example from Western medicine about anything. And that'd be fine, right? But to talk about like global poverty and women's health, which is work that I do, but it's more contemporary. So I was like, okay, but actually I do have an answer for you, which is that what history does is give you these big structural approaches to these individual women's stories. You know, instead of like, oh, this poor lady, she doesn't have any choices. Oh, this lady, she has more choices about having children. The reason that they have those choices is larger structural factors.
But anthropology does that too.
To a degree, anthropology does, but history does it better.
I agree. I agree.
Yeah, it does.
Well, I think your
It
quotes
actually
in the
does.
beginning
That's
were
a good
really helpful.
point.
Actually, the 2 quotes that you shared in the beginning.
Yeah.
I think that's really helpful to challenge students and say like, so right, we can go back and say, well, this is just horrible in 1927 in Morocco. But have them identify the more subtle historic. So, you know, challenge them and say, 25 years, you're still going to be a practicing physician. But you know, take that same lens that we're viewing all these things however long ago and kind of make parallel. I don't know, that's kind of what I got from those quotes.
At the macro level, I agree, and I believe. I'm glad we had the contextualization of your chapters, but I found that our discussion along the way of the narratives didn't integrate it. It didn't draw from it as well as it could have, and I think that speaks partially to the richness of the narratives themselves. I mean, it's very hard, right? Because we're trying to do things that are distant in both time and space, and that really makes it doubly difficult for a trainee in the early 21st century U.S. to think through.
Well, I actually think that we're having difficulty with this across every single portrait.
Yeah.
That every single portrait has not really integrated a discussion of the scholarship as well as I envisioned, or whatever, you know, as well as I would like. So I don't think it's actually particular to history.
No. That's a good point.
I would say, you know, while you were giving the PowerPoint, I kept thinking, okay, how do we connect this to Farmer, structural violence, and so you can take sort of the historical example and the contextualization historically, talk about how, you know, these are examples in the past of structural violence structures, and, you know, then link it to the narratives. So that could maybe be the thread. I don't know.
And structures are inherited or historical products.
Correct.
But also you can't understand it without understanding.
Well, and I think it might help
You really
the
can.
2 presentations to have to start with the historical background about like colonialism in Morocco to kind of frame it, then have them read the narratives, and then when you come in to have the discussion, talk about like the historical lens and why this matters and why we're using history that way. So then if they have the historical background and then they're reading it, they can kind of, without even knowing about it, like make the connections around like the structural issues and where they came from, and using that historical methodology to think about these things more critically than just looking at the cross-sectional time period and assuming it's in the present and posing present day values and technologies and all that type of thing.
Yeah.
It's probably, I mean, maybe my struggle is with the fact that the IVF material seemed very far removed from the history of Moroccan women's and child health.
Maybe that's where my interpretation was like assumed that there was similar structure that I brought that up. The concept of it became
You're bringing the culture from one to another.
They're not historically linked, except, I mean, they're not linked except that they're Muslim women.
Right.
But I didn't want.
Claudia's from Eritrea.
Right.
From
Maybe
Morocco.
it's not about
Right.
religion.
But maybe I missed because I wasn't spiritual. Maybe I missed from 2 to 2:30.
No, because we
No.
started late.
No.
No
I mean,
excuse,
the,
Carrie.
the purpose of that, so the part of the problem is that the question I was, the question I was given is not something that's easy to illustrate with a historical. And I gave them all their reading, and there was going to be like a riot. Like I gave them all of it. I was like, that's how I started. It was like, because Sandy's like, they'll read, their faculty, give them reading, and I'm like, no problem.
I'm pretty sure.
Load them up with reading, and then they were like, we hate this. Throwing rocks, throwing bottles. They were like, this is too much reading. Why are we reading all this dense stuff? So I'm like, okay, then. I said, so I'm like, okay, we're gonna just like cut this way down and focus on certain issues. Sandy said it's okay just to have certain questions, like from a historical perspective. It was important to me to have those two because Rania is a certain type of patient who is somebody that we associate with Western. Like the Western woman is the one who can travel the world and do her IVF and do whatever she wants and make these medical choices. But the poor downtrodden Muslim woman is in her own country where she has all these problems and challenges. And so I didn't want to have just the one or the other, although in principle you could cut the Moroccan component, only have Rania, but then there's no structural violence, which was something that Sandy wanted, and global poverty was something that Sandy wanted me to address. And so so that's why they're together.
I like them together.
And there are ways that Islamic cultural and family expectations impact both stories.
That's what I was thinking. I was assuming. But I think one thing that was illuminated for me when you went on something that seems a little bit like a digression to Lebanon experience is that there could be an assumption that religion is the overarching structure, but you can't make assumptions that one religious concept in one country is going to be the other.
Right.
And that to me was, I think would be an important takeaway, because if people will learn something about someone from an unfamiliar religion in one context, then it's that it's true for people everywhere about it.
Yeah, correct.
Yeah,
that was my because when I talk to these students at Rollins, it also depends on how you direct the discussion. So I really tried to push the discussion at Rollins more about like, what do you think about this individual woman and her choices? You know, how do you feel about what are these issues? And nothing about her religious, not really things about her religious background. In fact, it didn't come up at all for the most part of these students. Like at the end, I'm like, oh, she's a refugee from Eritrea and she has Muslim family. Like, do you see that as an issue? But there were other things that I was asking them to say, like, she has these expectations about family. Like, does your family have expectations about whether you're going to be a parent or not? Like, is there any pressure or expectation? And some of the students were like this, and some of the students were like that. And I'm like, that's helpful, right? And everybody's got everybody's got a family full of what my grandmother used to call her in-laws, the food and not this one. So everybody's got their own stuff going on. So
I think in terms of the historical context, I really like your chapter, but I think your PowerPoint is probably a better way to deliver that.
I cut the chapter down to like a half, but if you want to, you could push it to the recommended. And that would be your choice.
Or that'd be an alternative.
All right. Yeah, we can make it an alternative.
Like
Pick
either
one
have
or the
them
other.
view the PowerPoint.
Right. The
one or the other, or have them-
facilitator. We've done that for other portraits too.
So then the PowerPoint wouldn't be a part of the actual 75 minutes.
It could be, yeah.
But then
in some ways, I think the PowerPoint might actually direct the conversation to the structural. So if they're both in and you do the reading, but then you do all of the reading together, including your chapter, but then start the conversation with the PowerPoint, it's already going to direct how people are responding. And so I'm wondering if that's in part how you get to the historical as lens, is through the PowerPoint.
No, say that again. I'm not understanding that. Are you there?
No.
You are? Okay, sorry.
I don't know what Gwen was saying earlier. Yeah. Like frame it as history in the beginning. Like make that, like say history is the thing. Like name it. And just in naming it, you're gonna make students think.
And then
This is
the
history,
historical information.
and they're going to get to all those things with the narratives because they're compelling.
Well, and I think you mentioned the method
like the other,
the method of like micro history, and like using the individual story to reflect the bigger narrative. And I think maybe incorporating that as like the methodology or what they can think about, like how this portrait fits in, and that's how we're fitting in the historical methodology, and kind of explaining that. I think that would help too.
I agree.
Yeah.
In this PowerPoint though.
Right.
And history, and you said this, history sort of, looks at the individual to the collective or the broad structure, and the structures on the individual. And so that's the historical analysis piece that you can literally just put like as a line in the PowerPoint.
So if you, also.
Does that make sense?
Yes, it does. So, the question is like, for the PowerPoint, like how long do you want it, and then what do you want it to do, right? So if you want some of this, like this is history framing, this is methodology, blah, 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 and have just like one slide or maybe two that sort of frame it, like some of the introduction that I had, but enter it into the.
introduction.
Yeah.
You guys said 412.
Oh, I haven't seen it. Well, I'll see it tomorrow. Joanna did it. Yeah.
Right, but just how to, as a pedagogical strategy, if that was something that she did and it came to her worked, then maybe this would be.
I think that's right. Because I don't think for the students, we don't need to talk about how history of medicine has been left behind in health humanities, because they don't really care about that part. No,
They just want to know why it's relevant.
it was good for this, but we could, you can take that out and just put the parts that are about like, how does history help us look at a problem, scoping in and scoping out.
Yeah, that historical example I think does that, because it's, you have these big structural issues, and then it impacts this individual woman like in her bone. Like there's specific clinical outcome that has a structural origin.
Right.
Oh yeah, and then the other woman in her liver, liver. Yeah, it kind of. I was a translator for an eye surgery mission, and one of the things they did was tell the Moroccans they should have a cornea bank, and then the Moroccans were like, we have a cornea bank, but it's empty. And the American NGO was so surprised. Oh, really? And then the nurse said, because it was a lecture to nurses, she said, the rich eat us when we're alive. Why should they eat us when we're dead too? I was like, yeah.
That's a shit. Woo.
So there's like a way that the very specific physical is impacted by the structural, right? But that would be and then I could do, it depends on, so now it's more about what you want this to do.
Well, I think that part is the framing part, right? It's the historical context. It's the sort of historical patterning, right?
Do you feel the PowerPoint is necessary, or
I liked it. Yeah, I loved it.
Okay.
And I like that they're separate too. I like the background, like the context, and then the methodology kind of like separated out.
Oh, okay.
Oh, you do?
Yeah, because I thought it'd be good to have the context, read the narrative, talk about the methodology, and then have the discussion. Because then you can, right, because then they can think about it and then help frame their discussion.
I use that for I get this pro-comp session, and that slide is actually from my pro-comp lecture.
I think connecting it to social determinants of health is really good too, because that's something that they'll be really familiar. I hope that they're
Yeah, they are.
Okay, good.
Any other questions or?
I had like kind of, this is what I was going to mention earlier. You mentioned Michael having like printed text to be read out loud. And this is just my narrative bias, but story is received differently based on the voice that is telling it. And I think that's an important experience. So whether or not we want to say that's part of the history, whatever. But I think that having that activity as part of the portrait is probably powerful.
I
don't
loved
know.
it.
Well, the reason I did that is I could not rely on students having read anything,
Old teaching trick.
right?
But
And so I
there's
chose very
more-
specific
yeah.
passages from the
Right.
assigned readings that I knew were rich enough to carry a discussion.
But like, for example, for Jody's, we read out loud.
Well, we did that. We did that in mine.
Yeah.
Oh, so
But
you think it should be part of every?
Like reading out loud Granya's, like hearing her voice and her words aloud as part of the discussion of the text. You don't even have to like select what you want, just have a student he's like read a line that, you know, so Matthew's like, she was annoying, I felt like she was entitled to say, read a line where you like let's hear that entitlement. And so when he actually says,
And that goes back to Allie's point, like where are we locating that entitlement, right?
But
Then we
that's
go back to
also
the
my
text.
literature.
Yeah.
I mean, that's kind
Well,
of.
this is like I call that like dental extraction. Like this is like when you have to lead discussion on a text with a group of students and you're pretty sure that they're not ready, which is often the case. So it's not enough just that you read and you got your stuff. You also beforehand have handpicked certain passages so that if they're completely unprepared, at the very least, if they have the text, you're like, who can read blah, 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 page 6, paragraph 1, go. So that at least you can have a conversation about that. I mean, actually, this is something that I do when they're not ready.
Yeah, that's why he said he was doing it.
Or it could be, because it can be for multiple
But
levels.
it can also be,
But in the teaching guide, I mean, we can just,
may change my
but we can just put in the teaching guide, like, if facilitator wants this read out loud, fine. Like, I don't, Rebecca didn't choose the passages to read out loud, did she?
No, I did.
You did, right. So, you know, you can put in
But
like
I'm
a
pretty sure
note.
during our session, I think people read words from the text out loud.
I'm saying for Ellen, sorry,
Yeah.
because we're running late, but for Ellen, she just can put, or I can put it for you. You know,
Yeah, you could.
facilitator can opt to have
do that.
students read
Yeah.
portions out loud,
but
period.
it's an effective.
Yeah.
I mean, it's definitely effective, especially when there's a lot of reading.
And my question is whether or not it's like we say this is an option to do, or we should encourage them to start there.
For every single portrait?
That's my question. I don't know.
I think
Like,
it's
do you
up to the facilitator.
I think Joanna had a comment.
Oh, I was just going to say that Gretchen yesterday, you know, and she was saying, you know, I think she thought it was important that I, as a facilitator, chose the sections that I wanted to discuss. That's kind of that kind of connects, I think, the person that's delivering it to the content too, and allows them to choose things that they want to emphasize. So it allows a little bit of autonomy and connectivity, I think, with the person that's providing it. The other thing is that she actually is sent, we're doing one where she has the actual person, the transcript is actually, she shared a piece of it orally. So we're having them read two and listen to one with that exact point of saying, how is that different, having the person actually say it versus you reading it? And I think that that's maybe a brief point that could be brought up. Not that the students are going to provide the same inflection, but you know, I think that there's something to that. And I agree we could make it optional, but I would say that we would encourage it, because I really think that it brings just the group dynamic and folks kind of participating, you know, getting their voices heard even in that way, I think was a good aspect to it. So I just
No, I agree with that. I just don't, I'm afraid,
things.
I fear making something like that mandatory.
Yeah.
I think it is important for the facilitator to have the autonomy.
What if you just embedded it into the teaching guide, like under the objectives? Like objective 1 is they'll discuss personhood or something, and then you could have like in like C sections, blah 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 blah, where it kind of this might help elicit this objective if you read this out loud, or if you focus on this part or something. And so if there's specific objectives that facilitators are more interested in, they can quickly look at the teaching guide and not have to themselves flip through and find.
Well, I'm just thinking too, as a pedagogical tool, say there's value in hearing the text read out loud.
Sure.
That's kind of all I'm saying.
Yeah,
It's
yeah,
just like,
I agree with you.
it is an option, and it's sort of an alternative way to present something, because when I think about different learners and the way they hear things, like even myself, if I read Ranya's piece and I hear Ranya's piece, I'm getting different things from that,
I agree.
even just in my own head. So I feel like it can be a useful tool.
Overall, though, I think
But-
this portrait really works
Very
well
good.
together,
I like it.
and it's quite cohesive. And I think the teaching guide is very well written and extensive and good for any
Yeah.
facilitator.
I agree.
No,
So,
it's very good.